Buenas tardes and half a day to everyone. Welcome to your Guam Legislature. The Committee on Finance and Government Operations is now called to order. The time is 2:03, 2 o'clock and 3 minutes in the afternoon. This is May 5th, 2025. First notice of this public hearing was disseminated to all senators and media outlets on April 28, 2025, with its second notice disseminated on May 2, 2025. The hearing notices were also made available on the Guam Legislature's website, our legislative calendar, and the Government of Guam's public notice portal. The committee will now hear Bill number 44-38 COR, introduced by Committee on Rules by the request of Magaʹhågan Guåhan, the Governor of Guam, in accordance with the Organic Act, an act making appropriations for the operations of the executive branch of the Government of Guam for fiscal year ending September 30, 2026, making other appropriations and establishing miscellaneous and administrative provisions. Today we are hearing the budget as it's relative to the Guam Memorial Hospital. Joining me for this budget hearing is Vice Speaker Tony Atta, the Vice Chairman of this committee, the Chairwoman on Health, which is our Senator Sabrina Salas-Mantanani, Senator Sean Gumatauta, Senator Therese Terlai, and Senator Tello Taitigui. Those testifying on Bill 4438 relative to the Guam Memorial Hospital Authority, please take a seat at the table at this time. Before we begin, I'd like to remind everyone in attendance of the Legislature in Guåhan's general rules of conduct. Individuals testifying shall first be recognized by the chairperson before speaking and shall state their full name for the record-keeping purposes. Questions and testimony shall be confined to the substance or nature of the bill on the agenda. Personal inferences to the character or motive of any senator individual testifying are not permitted. The chairperson of the committee may order the removal from the hearing from any member from the Legislature in Guåhan or public audience who fails to observe proper decorum pursuant to the 38th Guam Legislature Standing Rules. Any violation of this general rule of conduct will result in immediate removal from this public hearing room. At this time, as is customary during the budget, we have our panel members to be sworn in. So, Sergeant-at-Arms, please swear in the panel.
Please stand and raise your right hand. Under penalty of perjury, you will affirm that any and no information you provide today, whether it be verbally, electronically, and in writing, be the truth, the whole truth, and nothing but the truth. Mr. Chair, on the oath, you may proceed.
Thank you, Sarge. So with that, we will now proceed to hear testimony on 44-38 COR relative to the Guam Memorial Hospital Authority. I guess I'll start with the CEO, Ms. Lillian Posadas, and I understand you have a PowerPoint presentation, and so I think we'll just go through that first, and then are your panel members testifying, or are they here in support and for any questions?
Some of them will speak on some of the slides, PowerPoint slides. Some are here to answer whatever questions or provide you whatever data or information that we may not have in our PowerPoint slides. So they're available. Thank you.
Lillian, I'll give you the latitude. And so you just conduct it how you want to until you're completed, and then we'll start for questions. You may proceed.
Okay. Thank you, Senator Christopher Dueñas, and buenas and half a day, Senator Christopher Dueñas, Chairman of the Committee on Government Finance and Operations, Vice Speaker Senator Tony Atta, Senator Sabrina Mantanani, Chairwoman of the Committee on Health and Veterans Affairs, buenas, Guahu Lillian Perez Posadas, Hospital Administrator. I'd like to introduce our panel here. To my right is Rodalyn Gerardo, who is our Assistant Administrator of Operations. To her right is Dr. Rick Eusebio, who is our OR Director. And to Dr. Eusebio's right is Mr. Jesse Kenya, who is our Personnel Services Administrator. And then to my left is our CFO, Ms. Yuka Hechanova. To her left is Jordan Paulun, who is one of our legal counsel. And then to his left is Mr. Zaudi Tagadi, who is our Associate Administrator of Operations. And then in the back, we also have some of our Executive Management Council members, Nursing Director, and the Assistant Administrator of Professional Support Services. And we have Ms. Saidi Taitsaken also, who is also part of the FISCAL team. So, Oh, yes, thank you. We have one of our Board of Trustee, Edgar Aguilar. He's one of our trustees with us to support us. And if you have questions of him, he's hopefully available to answer whatever questions you have. So, okay, let me proceed with my opening remarks. As I said earlier, Guåhan Lilian Perez Posadas, Hospital Administrator. On behalf of the Board of Trustees, management, medical staff, employees, and the patients we service, thank you for giving us this opportunity to defend, explain, justify, and validate the hospital's fiscal year 2026 budget request. We hope to engage in a collaborative, constructive, deliberative, and strategic thinking dialogue. With me this morning, I've already introduced our team, and I think I don't need to introduce any more. There is one more member of our executive team, and that's Ms. Danielle Menglone. She is our Administrator of Quality, Patient Safety, and Regulatory Compliance. We also have Dr. Larry Lizama, who is our Skilled Nursing Facility Medical Director, and Ms. Pauline Lizama, who is our Department of Corrections on-site clinic manager, nurse manager. And if I may, Senators, I want to make it unconditionally and undeniably clear without sounding monotonous or cynical. As GMH is Guam's only public hospital, it is therefore a safety net hospital. What this means is that GMH has a legal obligation and responsibility to provide health care for and to all individuals, regardless of their insurance status or ability to pay. This legal mandate requires GMH to serve all populations. GMHA is the go-to public hospital for the people of Guam, especially for the underinsured, uninsured, and most vulnerable population. It is the only hospital that serves the maternal child health MCH population. We are it. I know you all know this, but I just want to articulate and reiterate this fact as emphatically as possible. If we cannot provide or sustain basic medical care to everyone who enters the hospital because of the limited resources, be it financial, staffing, or supplies, then we all fail in our duties and responsibilities, and we run the risk of closing the hospital, which we all hope we do not get to that point. Therefore, I, and on behalf of our governing body, the Board of Trustees, our Executive Management Council, all our GMHA leaders and managers, employees, medical staff, and of course all the patients, we humbly ask this legislative leadership within its appropriation authority, responsibility, and role to support the hospital's funding needs, including the additional $21.9 million funds we need to keep the hospital operational with all the essential clinical and non-clinical services. I also want to emphasize and reiterate that GMHA does not get 100% reimbursement by the different payers. There is empirical evidence throughout the U.S. that payers such as commercial health insurance plans and federal insurance programs underpay and deny claims submitted by hospitals for services provided to their members and subscribers of their health plans. Hospitals across the U.S. are closing, primarily due to financial issues affecting their sustainability and viability. To put it all into perspective and to hopefully assist you with what we are asking, attached is a recent literature from the American Hospital Association entitled Cost of Caring: Challenges Facing America's Hospitals in 2025. As noted in that AHA literature, hospitals are not only centers of care, but also vital economic engines for communities. On that note, Senators, please allow me to restate our request that as GMHA is Guam's only public hospital and is a safety net hospital, it is imperative to amend the GMHA fiscal year 26 budget to include the 21.9 additional funds. I just want to quote, close my opening remarks with a quote from that AHA article. Supporting hospitals means supporting patients, communities, and the entire healthcare system of our island. Sidus Maasi. We can now begin our PowerPoint presentation. We can start with the first slide, which pretty much spells out our mission, committed to forward-thinking, compassionate forward-thinking, quality-driven, and safe healthcare that honors our community. Next slide, please. This is the mandate that requires us to then again provide the services to everyone and anyone who comes through our doors. We provide critical care, we provide family services, and we provide all kinds of diagnostic procedures in our facility. Next slide, please. And I'm going to hand it over now to Ms. Yuka, our CFO. Thank you.
Good afternoon, Senators. Thank you for being here today to listen to our presentation. Slide 3 begins with an overview of the FY2026 budget. For FY2026, GMHA's projected funding sources of $191.7 million will cover 90% of the projected operating expenses of $213.6 million. GMHA is requesting an additional $21.9 million, which is only 10% of the operating expenses. Our funding sources include GMHA collections of $133 million, budgeted appropriations of $54 million from the General Fund and Pharmaceuticals Fund, and $4 million from the Department of Corrections for the clinic services. This $21.9 million represents a funding gap that will result in unmet needs of the hospital. Next slide, please. Maintaining current services. With the $21.9 million, we can maintain current services. Without it, GMHA will have reduced capacity that will require bed closures. Our patients will have to wait longer in the ER for a bed. We will not be able to pay vendors for pharmaceuticals, oxygen, and vital supplies. We will not be able to pay contractors to service our medical equipment, our elevators, our boiler, our water treatment system. We will not have enough nurses and doctors to care for our patients. Next slide, please. GMHA has been exploring several cost containment strategies to include workforce reduction, outsourcing space and resources for outpatient clinics, and reevaluating all contracts for travel nurses and physicians, among other contracts. This is in light of the possibility of us not receiving the funding. We will really have to go back to the drawing board, and we are exploring cost containment strategies right now. Next slide, please. GMHA expenses have increased dramatically since the COVID-19 pandemic in 2020. Labor costs continue to be the largest percentage of hospital expenses. As noted in the recent cost of caring report from the American Hospital Association, the nation's healthcare systems are facing persistent cost growth and inadequate reimbursement. We are struggling to maintain access to essential medical services amid workforce shortages, supply chain disruptions, and tariffs. For FY2026, GMHA's most notable increases in expenses are expected in personnel costs, contractual services, and supplies. Personnel costs for FY2026 are expected to be $9.4 million higher than FY2025, mainly due to the high cost of medical and dental insurance premiums and the retirement rate increase. GMHA also factored in $1.8 million for nursing and professional support technicians' pay increases. However, the Department of Administration recently did not approve that pay increase, so that can be adjusted in our budget. Contractual costs are expected to be $2 million higher due to the continued need for contract travel nurses and physicians. Supplies and materials are expected to cost $2.2 million more than this year due to increases in the cost of drugs, liquid oxygen, and medical supplies. Next slide, please. Personnel. An increasing area in personnel costs have been in employee benefits, which are more than double for FY2026 than FY2020 amounts, while salaries have grown 36%. There have been several pay plan adjustments, the nurse pay plan in 2021 and 2024, the law enforcement plan in 2022, and the general pay plan in 2023, all with significant impacts to cash flow. Salaries and benefits in FY2020 was $85.1 million, and in FY2024, it is $138.4 million. Next slide, please. For billings, our revenue cycle staff in billing, coding, medical records, registration, and follow-up receivables have worked tirelessly to ensure claims are billed on time and carefully monitored to ensure maximum reimbursement. So far in FY2025, we have been on target by billing all gross charges. FY 2024 billings were significantly higher, as you can see in the slide, due to catching up on many claim delays from the network shutdown and Typhoon Mawar in FY 2023. Next slide, please. Collections. Since FY 2024, collections have been impacted partly by a 50% clawback from the Department of Administration for Medicaid advances of $26 million. GMHA has paid back the advances. However, additional amounts have been deemed advances by DOA, such as a $5 million pharmaceutical fund advance in October 2024 and $4.8 million in travel nurse payments they made for us in 2022. In FY 2024, $9.4 million was paid towards the Medicaid advance, and in 2025, $10 million. If the advances were truly GMHA collections, our collection rate on billings would have been 40% instead of 33%. We also experienced challenges with some of our payers. Next slide, please. Such as social cases. GMHA continues to provide care for patients deemed social cases that do not have any caregivers and have no acute conditions for hospitalization. Currently, $51 million is the uncollectible amount for social cases after these patients have exhausted their Medicare and Medicaid coverage, but continue to incur charges due to being continually hospitalized. Next slide, please. Although we have been able to help self-pay patients apply for Medicaid, old self-pay balances are a concern. Despite our best efforts to collect, GMHA's old self-pay receivables are $222 million. In FY 2026, we plan to outsource collections of old accounts while our collection staff work on current accounts. We continue to encourage patients to execute payment arrangements, apply for sliding fee discounts, and tax garnishments are also a means for us to collect. But many patients simply do not have the means to pay their hospital bills. Next slide, please. A large part of our Medicare claims are adjusted for amounts uncollectible due to the fixed per diem rate. Our FY 2024 Medicare cost report showed that the current cap per discharge Medicare patient is $13,000, while the actual cost of discharge was $28,000, a difference of $15,000. What this means is that in our cost report, it calculates that it actually costs us $28,000 when we discharge a Medicare patient, but the cost report says that we are capped at $13,000 for that discharge. Since FY 2020, the cost of the COVID-19 pandemic, the gap between our reimbursement rate and actual cost has significantly increased. It's really since the pandemic that we've noticed the significant gap between what Medicare is paying us and what our actual costs are. So rebasing our target rate to more current rates would help improve our reimbursements. One challenge in this area is the audit of our cost reports have slowed down significantly. The last audit was for FY 2019, and it's the CMS contractor Noridian that performs these desk reviews and audits of our cost report. And for some reason, FY 2019 was the last one. We started FY 2020, but that fizzled out, and they're going to resume the audits. We had a meeting with them last month that was arranged by our congressman, and we brought it to their attention that the cost report audits had slowed down, and they're going to look into it so we can resume those audits. When we have audited cost reports, that gives CMS accurate, verifiable information on what we would request in terms of rebasing. It gives them better numbers to rely on. But we're also exploring other more permanent solutions, such as a critical access hospital designation, where we would receive 101% of all Medicare expenses. Instead of going back every 5 or 10 years to determine whether we need our rate rebased, the critical access hospital designation would be something more permanent for us. And we're getting assistance with with this endeavor from the congressman. He arranged a meeting between us and him and his staff, and they're going to help us explore that option as well. Another thing we would need in this area is we really need to hire our own consultant to help us explore all these avenues and options that we have with Medicare. We were working with DOA to get help on their end, but it's been very slow to progress. So we'd like to move on and possibly get funding for a consultant to help us push these issues. Next slide, please. For Medicaid, we also have reimbursement challenges, but mainly because Medicaid mirrors the Medicare per diem rates. So the reimbursement challenges are very similar. The balances in the Medicaid table that you see there of $19 million are for charges that we haven't billed yet and haven't been paid yet, but it's also a large portion of that is for the social cases that are still covered under Medicaid and still in the hospital. Next slide, please. Take Care Insurance performance. Although we continue to strengthen our relationship with our payers and work closely with them to resolve billing issues quickly, delays in payment have been extremely stressful given the needs of the hospital. Payment is expected between 31 and 45 days of the bill date. Our challenges with Take Care have been delayed payments and settlements to clear old claims that after time become very, very difficult to reconcile. Our GMHA legal team has issued demand letters for those claims that exceed 45 days and are considered late. We also charge interest at the end of the month for those claims that are over 45 days. Next slide, please. For Select Care, our challenges are a little bit different. Select Care does pay. They pay us every week, and they've been pretty current. However, they have been denying claims for professional fees for physicians with private clinics, in addition to denying payment for IV infusion administration charges, and this is now amounting to approximately $800,000. So we have ongoing discussions with them regarding this, and now we've reined in our legal team to help us resolve these denials because they're getting very expensive. Next slide, please. Government charges is also, and reimbursement is also an issue. The main reason here is we have very old DOC receivables for inpatient care running about $3 million. This is for pre-2020 inpatient claims, and there's also some old workmen's compensation claims that haven't been paid. And if there really will be no possibility to receive any collection on these accounts, we will propose a write-off for these. Next slide, please. And our patient population here, most of our patients are covered by Medicaid and Medicare. And we continue to see more self-pay patients moving to Medicaid because we've been assisting them with the applications for Medicaid or MIP coverage. However, for Medicare and Medicaid, as I've explained, we are limited to a per diem rate for inpatient charges. And that current rate is $1,689 for inpatient stays, regardless of what charges are incurred. And with the increases in labor and non-labor costs, this has a significant financial impact on GMHA to provide care for the patients. Next slide, please. For accounts payable, we are at $20.8 million as of May 2nd, 2025. The legislature did graciously make supplemental appropriations to GMHA in October 2023 for $30 million. In July 2024 for $1 million for the merit bonus payout. And in October 2024, we got $20 million. And these supplemental fundings have brought tremendous relief as we were finally able to pay vendors and release our credit holds. However, our payables are now at $20.8 million, with the largest amounts owed to vendors for supplies and pharmaceuticals and even payroll payables for withholding taxes and insurance premiums. And now we have amounts climbing for CIP projects. Our current monthly cash requirements are between $16 and $17 million per month. and our total cash receipts average about $13 million a month, and this leaves a $3 million shortfall every month. Next slide, please.
Sorry, is that on this slide?
The payables.
No, your summary, what you said about the net revenue.
I can provide my testimony.
Could you just repeat that then, about the net revenue part?
The revenues?
Or you said that you're short, I don't know, your monthly shortfall?
The current cash requirements, so to pay for payroll and suppliers and vendors, our cash requirements are about 16 to 17 million a month, and our cash receipts total average about 13 million a month. So we're short about $3 million a month. And I'll turn it to Rodalyn for the CIPs.
So on the CIPs, in the packet that you received this afternoon, there is a listing. This is the same listing that was provided in the original budget submission. But what I just kind of wanted to walk you through it. So in addition to our operational fund request of $21.9 million, there is also a $29.3 million request for CIP. And so in the listing, it looks like this. So what you'll see is that we color-coded it, red meaning the most critical that we would need within 0 to 6 months as far as identification of funding, yellow meaning 6 to 12 months, and then blue meaning 9 to 18 months. You'll see, again, the total is $29.3 million. The biggest one in here really goes and speaks to our IT infrastructure. So this is related to our electronic health record and our IT network infrastructure. And so I know that in past hearings, we've been asked about where are we on our electronic health records, and we've been informing you that because we don't have the identified funding source, we're unable to procure, let alone put an IFB or an RFP together to procure the electronic health record. But in line with our fiscal year 2026, it's actually in line with our 5-year CIP plan. The electronic health record is there, and it's still an estimate, but the estimate is at $14.5 million, and then the IT network infrastructure is at $5 million. Again, these are all estimates. But just to show you that there are needs, critical infrastructure needs that the hospital does have, and so, we wanted to be transparent that these are the needs that we do have. But also in line with our CIP is the removal and replacement of our main electrical distribution panel, sub-panels, and emergency generator. That is, at least for the first year, the estimate is at $5.1 million, and that's on there under utility systems projects. But we've also summarized it in the spreadsheet, in the PowerPoint presentation for you all. Thank you. Next slide.
So there have been some talk about legislative proposals or amendments that can help GMHA advance its interests. So I will take a couple of them, and then Jesse Kanga will also address a couple. At one of our last hearings, Senator
Maybe you can just state your name for the record.
Oh, sorry.
Yeah,
Jordan Pauline, Legal Counsel. At one of our last hearings, Senator Montanani was talking about procurement reform, and I know the governor has addressed that as well in her State of the Island address. And so we have actually convened a group of procurement employees at the hospital to get together and review our procurement regulations and code, and we're going through that line by line. One of the biggest challenges we run into, especially at the hospital, is the limitation of $25,000 for small purchases. a purchase of linens regularly will even exceed the $25,000 threshold, and it just adds to delays to getting certain basic goods and supplies into the hospital. So one of our proposals would be to raise the local small purchase threshold to be in line with the federal simplified acquisition standards. The current federal simplified acquisition threshold is $250,000, but we're open to discussions, anything from the old threshold of $100,000 up to $250,000, and we will have we have circulated, I think, to a couple of the senators a written proposal on that portion, but we can also circulate that to the rest of the members. One of the other things we persistently run into problems with on the legal end is the pharmaceutical fund allotment. When the pharmaceutical fund was enacted into law, it designated 6.19% of the pharmaceutical fund to Guam Memorial Hospital Authority as part of the business privilege taxes. What happens every year when we get through the budget is we're given a sum certain as an estimate of what those BPT collections are going to be. And so when collections actually exceed the estimates, we're never actually given 6.19%, we're shortchanged, but when estimates do fall below and collections are short, they do withhold from us that same portion of the allotment. So if we can write into the budget bill or some other law some way to actually audit or true up so we actually get 6.19% of the pharmaceutical fund at the end of the year, that would be one way to help with the cash flow.
Okay. Thank you, Jordan. As senators, my name is Jesse King. I'm the Personnel Services Administrator. The other two amendments that we'd like to request, first is to the extension of tax credits. Public Law 35-138 established a new chapter, which was tax credits for GMHA. It was $1 million max per year for 5 years, and would allow businesses to procure much needed medical supplies and equipment. Unfortunately, FY2026 reflects the first budget act which would set aside the unpledged BPT. So we're asking for an amendment to the sunset provision to extend out to 2030, since this is the first year that GMHA would be able to work with businesses to get the tax credit. The final amendment that we'd like to request is similar to a public safety recruitment cycle. If we can implement a nurse recruitment funding in our budget act so that we can recruit for the anticipated graduate nurses out of the University of Guam and the Guam Community College. And we've drafted up the text which we can furnish to the committee and are available for questions. And I'll pass it back to our CEO for questions.
Thank you. Mr. Chair, Senator Chris Duenas, before we move on, I know a lot of you senators are probably really just wanting to ask us some questions, but I'd like for Dr. Eusebio to be given a few minutes to speak. Thank you.
Certainly. Proceed, Dr. Eusebio, and thank you for coming.
Okay. Thank you. Thank you for allowing me to speak, Mr. Speaker. Basically, in regards to my practice here in over 35 years of surgery in Guam, and I've been through all these budget hearings through the years, and with monies appropriated, monies not appropriated, whatever. But I've witnessed over the years this vicious cycle, really vicious cycle of failure, and that's what this is. And it's based on a subconscious belief. Quite honestly, listen to me. This is based on a subconscious belief that healthcare is free, and it's rooted in experience that originated in World War II, when the Navy established a system where everyone received free healthcare. This attitude has been pervasive in this government system, which all of you are participants through the years and is present today. The reality is that healthcare is not free. Hospital, physicians, nurses, and ultimately the patient pays, whether receiving good healthcare or no healthcare. This is the crux of the matter, quite honestly. And the question is whether you wish to uncouple yourself from this vicious cycle of failure, or is it even possible? I don't know, but it's up to you. I believe this can be accomplished, however, through effective management, free from political influence, efficient operations, an exception from procurement regulations, enforcement of collections, and the government paying for their mandated responsibility of providing care to anyone presenting themselves to the emergency room that is uninsured, Medicaid, or the MIP program. I just saw the $222 million of uncollected monies, and we're asking for 21. It's unbelievable. Now, these are not subsidies, but expenses for services rendered. If I may use the metaphor, the government is mandating us to make bread and creates a store to sell the bread, GMH. However, it takes $1 to make the bread, but the government only gives the store 60 cents to make the bread, and yet allows people to walk in the store and take the bread for free or pay less than $1 to make the bread. How is this store going to be function? How is this store going to survive and continue? The fact is that the GRMC exists, and it's good that GRMC exists because it demonstrates the possibility that a private entity can be successful in Guam. It provides patients with an option, but for GMH to compete with GRMC, we can't compete with one hand tied behind our back. A truly autonomous GMH in a new hospital building will be competitive, certainly. However, unless these issues of procurement, drugs, being unable to buy the drugs and yet charge the patients the appropriate amount, all these things are small, but these issues have to be resolved, and the only way we're going to resolve them is really to make GMH, my feeling is to make GMH truly autonomous. And the thing is, this has to be resolved before we go to the new hospital. Because unless you resolve these issues, you're going to have the same problem in the new hospital, and it's going to fail. It's going to fail. So it's up to you to try to resolve these issues and uncouple ourselves from this vicious cycle of failure. Thank you.
Dr. Eusebio. Lynn, is that complete, your presentation?
Yes, sir. We're ready for the questions.
So I'd like to address a couple of things before going to our healthcare chair. But I want to also welcome our speaker, Speaker Blas. Thank you for joining us, as well as Senator Calvo and Senator Will Parkinson. It's an interesting presentation, Dr. Eusebio. I think that's the magic key that nobody's been able to come up with and unlock. I got to say that unprecedented in at least 2 of the last fiscal years, 23 or 24, and currently, the general fund is at unprecedented levels in terms of the past on trying to help GMH get through the troubles it has. In fact, as it climbs, GMH as an authority is starting to look like a line agency, simply because of the ratio that's climbing in terms of general fund appropriation aligned with the services and that's charged for the fees. So that's a great thing to explore. I don't know what more authority we have to give to go out there and knock down doors and collect truly what you're billing for, but it's going to be an exploration nonetheless. And thank you for bringing that to light. One thing I want to mention, Ms. Lillian, is I'm getting a lot of messages from other physicians and other, particularly, of course, GRMC, and then even some questions from Naval Hospital, and the consistent statement from GMH that you take all patients. And I guess the only issue that maybe you can expand on is they're saying all hospitals take all patients. They can't turn them away. Whether you show up at the door at GRMC, whether you show up at Naval Hospital, because that's the standard anyways of care for divert or whatever ambulances are going to nearest hospital, those patients at least must be stabilized and get into a condition whereby they can get services elsewhere. So Can you clarify that statement? I just wanted to make sure I put it on the record because I'm getting so many questions about it from other physicians and other management from the two institutions.
Absolutely, that's a very good question. Yes, all hospitals are, again, they have that mission to provide care, but they do have limitations. Like with the Naval Hospital, their primary focus is really for their active duty personnel who are injured. But of course, they work with us and as being part of the healthcare system on the island, that if there is an emergency situation and they are the closest point of emergency care, they do accept, unless they're full and they go on divert. So therefore, or their CT scan is down, they're not able then to accommodate that emergency condition. GRMC also, because they receive some federal funds, a lot of hospitals in the mainland, they are required to take a certain number of patients, especially if they're receiving federal funds. So yes, their doors are also open, and if there's an emergency situation, a trauma case up in the north area, and GRMC is the closest, so then therefore they accept, unless they're full in their ER, they're saturated, that's when we alternate the diversion. But yes, they are, they have that mission statement of, receiving and taking and accommodating whatever patients come through their door.
So just a summary to that. So Doc, I'm just going to do a summary. It's probably lead into what you're going to say. So just a summary to that is it like the common theme here that it's stabilize and as soon as things are going okay, transfer?
That's the EMTALA. If they come into their doors with an emergency situation, they are required and obligated to then take care of that patient under the EMTALA until that the service that they provide, the care that they provide, is not really at their level. They stabilize that patient and then they transfer that patient to the higher level of facility that provide that service. The other exception that like the GRMC does not really accept, although if it's an emergency situation, they accept pediatric cases and maternal child health, pregnant women. They accept, but they stabilize and they transfer to GMH because we are it for maternal child health population. Thank you.
Thank you. Dr. Eusebio?
It's true that all the hospitals accept patients, and particularly those patients who are emergencies. However, once stabilized, they transfer them to GMH. Almost always. Having been in Naval Hospital, GRMC, and GMH, every patient that is seen initially stabilized and transferred to GMH. The eventual care of the patient, the long-term care of the patient, is GMH.
Thank you, Dr. Eusebio. Just on the overall numbers, I just want to make a general comment. At this time, it looks as though what the governor has presented in terms of her revenue forecast above current fiscal year, and it was in the executive, kind of the executive summary of the budget, because obviously we're filling in all the gaps with the other agencies, but in terms of the executive budget, it appears as though the numbers when we talk about education, when we talk about the hospital, when we talk about just about every institution that receives some version of a supplemental, it appears as though that's kind of tracking. So I would say that probably that's the baseline right now. The real disappointing thing, and I think many of us will just continue to say this, I don't know where we're going to end up with the CIPs, but there was a funding source, and then now there's not a funding source, and so we're all stuck with that, and we'll have to figure out, how we navigate that. But I can say that we'll work as hard as we can. I'm glad to see that you have contingencies and you're working on contingencies. I just want to be upfront to say I think that's going to be necessary. So perhaps robust collections will get us somewhere, and some other rebasing. It seems like you've got the tools. It's just tweaking the engine. But go ahead, Doc.
Senator, I just want to say that we have a good law in that we have a law that says that all insurance companies and all those who have received care needs to pay for their bill. The problem is the enforcement of the law. Nobody pays attention to it. Insurance companies don't pay attention to it. You guys don't pay attention to it, in the sense that whenever there's a patient that is, whether it's a patient that has no insurance, or it's a Department of Corrections that owes a lot, it's not paid. And so a lot of times the insurance companies will say, well, you know, government Guam, they're not paying it within the 30 days or 45 days. Why should we have to pay for it in 30, 45 days? We need somebody, we need a law that enforces that Prompt Payment Act. And that's what's important. And I think that if you allow GMH to be able to build, to do it on their own, we won't need these appropriations.
So Doc, once again, the golden key, I'm hearing you. I want to make two comments to that. One, sue the insurance companies. You guys got that power. If they're not playing ball and they're not applying by the rules and they're not giving you proper consideration and turnaround times, you got to do what you got to do. When you talk about not for free, Doc, we are a government that struggles to give subsidy to the hospital. I agree with that part. But we are not collecting premiums. We are not managing premiums. We're not managing health care. What we're doing is we're making an appropriation in addition to those fees that we have an expectation, that you have an expectation to receive in a timely manner. The second part is, you know, we appropriate. We recognize that there are government agencies that use your services. That's an executive function. That money's got to be found internally. That money's got to be moved. The line agencies in the government of Guam, under the governor's authority, have transfer authority. If those entities, such as DOC and other, that send you patients cannot pay, there is nothing wrong with them receiving money from the governor's office outside of their appropriation to be able to pay their bills. What happens is it comes in the reconciliation in terms of how audited financials come out and whatever the likelihood of all those is. But if there's cash available under transfer authority and what DOA is tracking, there's no reason why the government shouldn't pay its bills. I'm with you, Doc. One thing I'm really frustrated at is that we have obligations in this government. And the bottom line is we don't cut checks down here. Got to pay our bills. And the fact is that every time we're working on an appropriation's not cash. That doesn't give you cash. Cash comes from DOA. They write checks. So my thing is I agree with you wholeheartedly. Let's work together on that to hold each other accountable, because we're going to get as close to as we can on your number. But the thing is when the rubber hits the road and you need cash, that cash comes from Mr. Byrne and his team. So I appreciate all of your presentation, Doc, and we'll look forward to continuing on with that as the hearing goes on. So I'm now going to turn over to the Health Chair, Senator Sabrina Salas-Mantalani. Please proceed.
Thank you, Chairman Duenas. Before I get into questions about FY26 budget, I wanted to get an update on the current financial condition of the Guam Memorial Hospital. Lillian, the last time we spoke about payroll, I think it was 2 weeks ago, it was net payroll. Were you able to make up the difference? Or Yuka, Ms. Hachinova?
We're actually behind on withholding taxes from January, and insurance premiums also, I'm sorry, that's February, and then insurance premiums back to January. Retirement, we are current.
Okay. And you have payroll this week?
Yes, on Friday.
And
yes.
How much do you have in your account now?
As of this morning, 1.7 million.
And you need how much to make gross payroll?
5.1. And the insurance companies, typically, Medicare pays us every day. Every day there's some kind of payment from Medicare, but from Select Care, Take Care, Net Care, the insurance companies, they usually pay us on the Friday of payday or Thursday. So those payments come in a little bit later. Same with Medicaid, it comes in sometimes Wednesday or Thursday.
Are you guys up to date on your utilities, GPA, GWA? I know there was a payment plan.
GWA, we are current. GPA, we owe about 3 months right now.
3 months?
Yes.
And how much is that?
That is 700,000.
When's your next payment due?
For power?
Yes.
We just paid January. I think it's middle of the month is when they tell us to pay.
I see. Sunday, $4 million was due to New West for traveling nurses. Were you able to make that payment?
No, ma'am.
And so what does that mean? What will be the result?
If we don't make a $2 million payment by May 9, they will no longer assign travel nurses, refer travel nurses to GMH. We have about 18 right now who are with us, and they have their deployment here are staggered, but most of them are here for 3 months. Once they finish those 3 months assignment, then they leave and there won't be any replacement. They will not replace them.
And US is just one traveling nurse, right, company that you guys go through. What's the other one?
The other one is Medical Solutions, and so we started utilizing their services pre-COVID. And then we continued on throughout COVID. Recently, they stopped sending travel nurses because we were behind in payment, but we're caught up with with payment, and so they've sent 2 recently. We have 2 Medical Solution travel nurses.
Okay, a total of 2, and then you have 18 from New West.
Total 18. I'm so
18
sorry.
from
Total
New
is
West.
18. Correct.
Okay. And if you don't make a payment of $2 million by May 9th,
they will no
depending
longer
on-
send nurses. New West will no longer send referrals to us.
Okay. There's also a deadline of May 7th, correct, for the risk assessment, I think, to HHS. Are you guys going to be able to make that deadline?
Yes, ma'am. We pretty much are finalizing it. I think we were supposed to transmit it today. We are transmitting it to HHS OCR today, the risk analysis that was completed by our contractor.
Who is the contractor, and how much are you guys paying that contractor?
The contractor is IS Squared, and we paid them $43,000 or $50,000. Total $50,000 is what we paid. And under the HHS OCR Corrective Action Plan, the HHS allowed us to have a sole source procurement for that because of the time sensitivity. We needed to get this done. They gave us 90 days from the time that we signed that agreement. And so May 7th is the 90th day that we have to make sure we submit it. But we're submitting it today.
That risk analysis, did it change any of the, I think it was $5 million you put down for IT. Is it still $5 million, or based on that analysis, is it going to cost more?
It probably, go ahead, Rod.
One of the things we did ask was for a preliminary estimate. And so our vendor, IS Squared, was to put together the preliminary estimate. I needed to check back with our IT administrator or assistant administrator as far as what that number is, but we were to get a rough estimate of what that was.
But it could possibly be more than the $5 million indicated in your budget proposal.
It could be, ma'am, because this budget was prepared prior to.
Okay. I'd like to go through now the potential cost containment strategies. The workforce reduction, it says here, full-time employees. How many full-time employees does GMH currently have? Is it 1,200?
Those are 1,200 warm bodies, so it's a combination of full-time and part-time employees.
So how many employees, if you were to do this workforce reduction, how much in savings would that bring?
If we go with a 10% reduction, that will probably be around 10 to 13 million.
Okay.
Per annum.
Per year. And how would that affect operations? Are we talking about critical employees? Are we talking about nurses, doctors?
Jess, you have a criteria, right, that you are going to be following?
Yes. Thank you, Senator Matanani. So we're probably going to be following, according to the Personnel Rules and Regulations, Appendix 2. It would outline for us a list of classifications that will be furnished to the CEO, and then the CEO would identify which positions would be affected. The procedures here was we would announce a volunteer opportunity first to see which positions would like to offer to be offloaded. Up until we reach our goal. If we're unable to reach the goal of the 10%, then we would begin the procedures for identifying which class of employees would be affected and which positions.
Under service contracting, explore outsourcing options and renegotiate radiology contracts. Can you explain that a little bit more, and also the cost savings for that?
Yes, ma'am. Thank you. What we're paying right now is that we pay for radiology reading services per hour. And what we're looking at to see if what we can do like we did in the past when we had Nighthawks, radiologists read some of our diagnostic procedures or imaging, we're looking at per read. So an hour can go by or 2 hours can go by, and the radiologist who's standing by to read will not have anything to read, but they're charging us, right now they're charging us per hour even though there's no reading. So that's what we're looking at, is to make it a per read charge.
Space optimization, outsource outpatient clinic space for cardiology, gastroenterology, and pulmonary services. How much in savings are you looking at? Or is this revenue enhancement?
We've just started looking at some of the options we can have for the outpatient services. Right now, their financial statements we've been preparing every month. It's sort of break even right now, and so we're trying to decide on ways where we can either rent the space to them, but give them the staffing and the space, the utilities, either that or have them manage their own professional fees. It's something we just really started recently thinking about because of the cash flow issues we have with buying their very expensive supplies. The supplies for cardiology and gastro are quite expensive. And so we're trying to think of ways and how other clinics also operate, where the doctor would come in and actually just rent the space and probably pay a portion of their professional fee back to the hospital in lieu as payment for the rent. Those are one of the very few options, but we want to keep going and finding other ideas where we can optimize that relationship and also continue the outpatient services in the hospital.
Compensation adjustments, reduce travel nurses, cut on-call pay. How much are you guys paying for on-call pay?
We're using the minimum wage, which is $9.25 per hour. So if an echocardiogram technologist, we need that person, that professional to be available for if in case the doctor orders an echocardiogram to be done right away, that echocardiogram technologist who's been on call for 5-6 hours after 5 p.m. earns $9.25 per hour to be then just readily available to be called in. So it's $9.25 per hour. So it's not just the echocardiogram technologists, but all staff who are on-call. That is what they earn. And that's a Board of Trustee resolution implementation. So we're going to bring it back to the BOT to see if we can reduce that $9.25 per hour to probably $5 an hour, which is kind of standard in some hospitals. That's what they pay on-call staff.
Can you break that down, like in terms of cost, I guess per month? How much do you pay out for on-call pay?
The annual for on-call pay right now is about $300,000 to $350,000. So we could potentially cut that down in half if we cut it from $9.25 to $5.
Mm-hmm. Is that per doctor, or is that?
That's just overall for the annual, yeah.
All right. These social cases and the financial impact, I know that we've had discussions that a assisted living facility is going to be opening in Tumuning. The government purchased a facility, and it's opening in the next couple of months. And the plan is to move the social case patients over to this new facility. Is GMH going to be funding any of that, or providing any kind of money for that new facility, or any kind of services to this new?
Not that I know of. It's going to be public health that's going to be administering and be responsible for that program. Former Senator Amanda Shelton, I understand, is the one in charge of making sure that that becomes a reality. And right now, they're doing the retrofitting of the facility, and I think they've got some ADA furniture in place. They're getting the elevator installed because it does have the frame for an elevator, but it just doesn't have an elevator. But they're working on that one, is what I understand. But I have no discussion with the governor or anyone else that says that GMH will then be covering whatever costs for that facility to be opened up. And so it's going to really relieve some of our bed space and then hopefully free up the bed for those patients who come through the emergency room to be admitted into those patient rooms. Hopefully that's what's going to be.
So in your FY26 budget request, there is no request for social case patients, correct? Because there wouldn't be a need to if they're moving to this new facility in the next couple of months prior to the new fiscal year?
There won't be any, but they leave behind a big bill that needs to be paid.
Yes.
Yes.
Senator, if I may explain a little bit. You can't send a homeless person out of the hospital. A lot of times the homeless patients are in the hospital and they're there for months, even a year, because you just can't send them out. And it's very difficult to deal with those issues, and it's not just one, but increasing numbers. As a matter of fact, I know the GRMC, in order to deal with that, even actually hired somebody to find a place to fly to the Philippines or go somewhere, find a place for them to go to. It's cheaper for that than to stay in the hospital for a year. Thank you.
Is it cheaper to put, have them in a hotel? If you...
Well,
you said
what's the question? I'm sorry, I didn't understand.
Is it cheaper to put these patients that you were referring to, Dr. Eusebio, in a hotel?
It depends. It depends on how long they're in the hospital. But obviously, if they're in the hospital for a year, then it would be cheaper to move them somewhere else if you can, rather than keeping them in the hospital.
Mm-hmm. TEFRA, I know this is something we always talk about. So the fixed rate is about $1,600 for GMH. Where are you guys in rebasing, and what should the cost actually be, the per diem rate?
We've calculated that it should be about double that, so around $3,400 to cover our Medicare costs. We have actually been waiting on DOA to provide us with a report. They've mentioned to us a few months ago that they hired a consultant that would work on the Medicare rebasing for us, but it's been very slow to get feedback from them. So we really want to start exploring getting our own consultant to not only look at the rebasing options, but any other options that we might have. We've really been looking at the critical access hospital designation so that it would be something more permanent than having to go back to CMS and ask them to rebase whenever costs get out of hand. And the critical access hospital right now reimburses at 101% of Medicare expenses. The only problem with GMH is we don't qualify because we're too big. The critical access hospital designation is really for smaller hospitals. You have to have less than 25 beds, and we have 160 something beds. But we are the only public hospital out here in the middle of the Pacific. It's very different than the landscape in the mainland where there's a hospital in the next county, there's a hospital in the next town. For us, it's just here, and then we have GRMC. So we'd like that designation, but it would definitely have to be something that's very unique and tailored to the Guam situation we have right now.
And is that designation authorized by CMS or
CMS?
CMS? Okay.
Yes.
All right. And where are you guys with? Have you had any conversations with CMS or?
Very briefly, when we met with Kelly Anderson, who is actually the director of the audit and reimbursement section, which is a meeting that was coordinated by the congressman. So this is really the first time we've ever had a really good dialogue with people on the Noridian side. It's always been very hit or miss with them, and especially after the pandemic, it just got really quiet. We don't get notifications, we don't get letters telling us our rates have been adjusted, and so that was part of the discussion we had with them, is they really have to communicate with us. So we got through that hurdle, and then we talked about the audit, and we told her about some of the things we're thinking of, including the critical access. But that discussion was also carried forward to when we met with the congressman and his staff, and they committed to helping us look into whether that would be a possibility or not. And they have their own connections within DC and the CMS side as well. So they said they would get back to us. And we just met with them maybe less than a month ago when they were here.
Okay. Is it a situation where it has to be either the critical access hospital designation or TEFRA? Can it be both, or do you know?
To my understanding, they're different because they're both very different payment reimbursement situations, whereas the TEFRA is really based on a cap that they set per discharge, and the critical access hospital will pay us 101% of the expenses.
Okay. Well, I've also arranged a video conference call with CMS for this week. It's 5 o'clock in the morning, Wednesday. Lillian, I'd like to invite you or whoever else you feel should be in on that call, and I'll send you that link. Thank you. I think that's all I have for now, so thank you.
Si Dusmasi, Senator Montanani, you did that in about 5 minutes. I've got a 10-minute clock going with follow-ups capability. So thank you very much for that. Vice Speaker, who is also the Vice Chair of this committee, yeah, you may proceed.
Thank you, Mr. Chair. Perhaps just a couple of questions. You were mentioning in your slide presentation about the I guess one insurance company that paid had a billing for 10 million, and then you guys had a settlement payment for 2.8 million from 5.3. What was the reason for the 2.5 million?
I can help explain a little bit of this. So there were a number of parts to this. We had a large billing outstanding, but then there was also a number of outstanding claims from 2017 and prior that they claimed GMH still owed them a reimbursement on. There was a reconciliation done by EY, I believe in 2019. Evaluating these things, we had some disagreements over what the actual EY report showed, but in an effort to resolve the claims that they say that the hospital owed them from 2012 to 2017, as well as their outstanding claims, they took a partial acceptance. They took a big cut of what they were claiming we owed them under that, and then we also agreed to settle the claims lower as a result of that. So a lot of that came out of that. And then we also, instead of going through a lengthy reconciliation process related to our claims that were outstanding, because they were having some computer issues as well, so that would have taken us a lot longer to get cash, we had proposed the reduction of our amount by our historical collection rate from them, which is about 75 to 80%. Because there is patient responsibility and other stuff that typically gets taken out of a billed claim. If you're on the HSA 2000 plan, every patient's responsible for the first 2,000. So we looked at that amount, reduced our demand roughly in proportion to that, as well as gave them a partial credit for the 2012 to 2017 claims that they claim that we still owed them reimbursement on, that they claimed that they had overpaid us in that period.
I see. So in the 2024 settlement issues, of the 2.8 million that you guys have settled for, how much have they paid?
They paid the 100% of that settlement.
Okay, and of the 10 million that is for the 2025 billing period, how much of that 10 million has been paid?
Outstanding right now is about 1.5.
1.5 million? Okay. And then you were also mentioning about outsourcing collections for old accounts. I mean, been down that road before, and it seemed to have bitten GMH in the butt on that one. So how do we look at doing things differently for outsourcing collections this time around?
A big part of it was really getting our accounts receivable aging cleaned up. So now we're at a good point where we can actually say these are the claims we want to forward to a collection agency. We have staff, as the collection supervisor, will be in charge of monitoring the progress and of that contract to make sure that we are collecting. We also don't want to keep the accounts with the collection agency for a significantly long time. We have to develop our processes so that at some point, if there's, with the collection agency, for example, 2 years or 3 years, and there's no movement on the account, then maybe we will move to write it off because it really is just not going to be collected.
So you're going with a collection agency versus what was done the last time?
Which was?
When they had a third party doing the collections for GMH?
I'm not sure what you mean. We're actually going to, because we don't have a collection agency right now for any of those very old accounts that were, the next step would be to write them off, but we want to take it a step further to make sure that we run it through another process to exhaust all efforts to collect on these accounts.
Okay. And tax refunds, garnishment, I know GMH does that quite a bit. How much are you looking at garnishing this time around?
We're not sure. We have submitted our listing. I think it's about $100 million worth of claims that we submitted to DRT. The part we're not sure about is when these taxpayers file their returns. Some don't file at all. But now that people are filing their taxes, we've been getting about an average of maybe $400,000 to $500,000 a month. That's right now during the active tax season, and then it tapers off around July or June, and then it picks up a little bit again in October. So it's following the tax filing habits of the taxpayers.
So has it been accounted for in your presentation that you've given us, that that's what you'll be collecting or hopefully to collect?
Yes, under the self-pay
Under self-pay?
estimates, yes.
Okay. And how about SNU? So what are going to be the plans with SNU once, I guess, this other facility gets put into play where social patients will be going? What are we going to do with SNU? Is there still plans to put that out for a private-public partnership, or?
It's a possible option, but we haven't yet really done a deep dive discussion on it. We're just concerned that if we do that, I'm worried that what's going to happen to those residents, where they're going to go. In terms of the new hospital, we are factoring in a unit for it to be a skilled nursing unit like what it is right now, although it is over there in Magaʹhågan Heights in that facility, self-contained facility, but the residents that are served there are the skilled nursing level type of patients or residents. And so we haven't really done a real deep dive discussion, although there is an interest from an off-island company that wants to either lease it or to buy it. But, we haven't seen anything in writing. It's all been just verbal, discussions from an entity from Texas. And so, but we want to make sure that those residents are not displaced.
Okay. Thank you, Mr. Chair. That's the only questions I have at this point.
Thank you, Vice Speaker Tony Yada. Senator Tello Tadegui.
Thank you, Mr. Chair. Good afternoon to my colleagues, and of course, good afternoon to our only public hospital, Guam. Thank you for all your hard work. And I was hoping today that we would get what we've gotten in the past, and that's a spreadsheet that you provide the legislature breaking down everything on the cost. Right now, we just got a spreadsheet that only says miscellaneous, and that's it. So there's really no breakdown of how much you spend for your supplies, material, workman's comp, drug testing, you know, off-island, mileage, regular salaries, overtime, benefit. Even though you sent us a staffing pattern, it's really nice to have this sheet because then we can compare to FY25 versus FY26 and the difference before that. I do have some questions regarding DOC. Inside your letter to the Oversight Chair of Appropriations, you mentioned that DOC, if you can just recover $4.8 million from DOC that they owe, but technically they owe $7 million. Is that correct?
Yes, for the inpatient side, it's about a little over $3 million for older claims when the inmates come and get hospitalized at the hospital.
Oh, so the older claim is like $3 million, and then the current one.
They're current on the clinic costs. So we bill them every month to run the clinic at DOC.
Okay.
That one is current. They've paid currently for that.
Okay, so what I don't understand is that on DOC side, the MOU between DOC and the hospital, there is an agreement of $4.2 million to cover that. But then, according to the director of DOC, that funding amount actually is to pay for the doctors. I believe Dr. Anderson, some of the nurses, the clinical employees. However, when I look on your staffing pattern, I see that you're requesting for this amount. Dr. Anderson's on your staffing pattern, and even your staffing pattern says DOC. But then yet, DOC is requesting from the, for budget, $4.2 million to cover the same cost. Can you explain?
So we run the clinic there, we staff it, and we also have the supplies, the pharmaceuticals are all given to them. And so at the end of the month, all of those costs are billed to DOC, and then they pay for that through their $4 million appropriation, and then DOA will pay us.
Then why are you charging on your staffing pattern for the doctor and the nurses for DOC when DOC is covering it?
Yeah, there are employees. They're on our staffing pattern. We pay them. We pay them their salaries. We pay for all the pharmaceuticals. We pay for the overtime and all the benefits for those employees. So we're just getting a reimbursement back from DOA for those costs.
If I may, Senator, the MOA, the cooperative agreement, is that GMH provides the health services on site. So therefore, it's GMH who administers and who provides the staffing and the supplies and the pharmaceuticals. It's all on us. They are GMH employees.
And you pay for that?
We pay for their salaries.
Okay. Then why is DOC asking for $4.2 million to cover those same costs?
Because we invoice DOC, and so then they reimburse us.
Right, I understand that. But yet your budget is requesting for salaries for those same individuals.
If I may, Senator, to clarify, what you see on slide 3 is a reflection of all the revenue sources. But for DOC's $4.2 million, it's not an added appropriation to the chapter for GMH. That amount is in DOC's chapter in the Budget Act. So we're reflecting the total estimated revenue sources that include self-pay, other payers, and DOC. But with regards to the Budget Act, only 2 sections are appropriated to GMH, and that's reflective on this, this sheet here. It shows operations, capital outlay, and the Guam pharmaceutical funds. So really, you're only seeing the 2 lighter shades of blue, and the amounts are 20.5. That's reflective of the pharmaceutical fund, and then the general fund.
Okay.
I understand the
Now,
confusion.
if you look at your staffing pattern that's on your website and the staffing pattern for proposed salaries, you'll also see on page, I think this was 47, toward the end, you have DOC clinical, nurse, several nurses. You even have Dr. Mark Anderson, physician, making, Mark Anderson making, he's not actually on there, but you have all the other physicians. I'm sorry, not physicians, nurses, staffing, clinical.
Correct.
They're all charged.
They are GMH employees.
Right.
So if you look at the total universe of what it costs to run GMH, it is $213.6 million. And there are a variety of sources that give GMH up to the amount we need for expenses. So that includes DOC. So it's not technically an appropriation that is given and requested by GMH. GMH only receives the two appropriations, mainly from the general fund and pharmaceuticals fund. That's the government share to the whole GMH operating fund.
Okay, but I'm seeing in a staffing pattern, if you go under DOC, you're incorporating that in your staffing request to pay that. And you have DOC asking for $4.2 million to pay for the same thing. That's what I just don't understand here. And if you look at your staffing pattern, it'll show you you're paying Dr. Anderson. And then I talked to the director this morning, and he said that their request for $4.2 to pay for the doctor. So it's almost like we're paying him twice. So,
if I could use a different angle, you also receive on the budget overview that there are other opportunities that we get, such as grants. So those aren't appropriations by the legislature, but we do factor that in as revenue to GMH. So in the same light, you can view DOC and that budget appropriation as revenue to GMH, but it is not an appropriation to the chapter that governs GMH.
Okay, when you talk about federal grants, that's why the spreadsheet's important, because you have one where pharmaceutical fund, you have federal matching grants, general fund.
Yes.
And so I don't see anything on federal match at all.
We'll give you a copy of the full budget packet, Senator.
Well, this is what we receive here, and this is what we're going by, so it makes it very difficult when it's not completed. You've done it in the past. I don't know what changed, what kind of system you're using right now. Okay, so let me move on because I'm being timed. Hold on. Okay, also in your salaries, you have one section for staffing. Let's stay on staffing, right? First, do you still have I think a Dr. Shea, radiologist, receiving $700,000 for a salary? Why is that so high? He's been getting that since 2019? Why is he still receiving such a high salary at $700,000? That's higher than anyone there.
He's an interventional radiologist, so he's got those specialty skills to do all kinds of procedures that are kind of invasive, but using really special techniques and, diagnostic procedures and treatment modalities. So, he's a very highly credentialed and highly specialized radiologist.
Is he contracted or is he part of the staff?
He's a GG1 employee.
GG1. That's quite high.
Senator, that's not quite high. That's standard.
At every hospital, Dr. Eusebio?
That's the average pay for an interventional radiologist in the United States, not in Guam. Understand that
in the
what
United
we
States
should be paying is a little bit should be even a little higher, because why should he come here? Why should he come here? That's the problem. The problem is that we can't attract physicians to come here because we don't pay them enough. But $700,000, standard. The average pay for a physician is $250,000. That's taking everybody into all accounts.
Are we still doing double charges for doctors, like give them one position? I think Dr. Uggan was in that situation. She was administrator and then she was a doctor or something else. And are we still doing that?
They're separate. They are separate compensation, Senator. We pay for the physician for his or her physician specialty, and then when we need their assistance and their energy and their time and the intelligence to help us with policies and procedures and training and all that, then they're in a different role. So we do pay them for that separate role.
Okay, the other one is in retirement contributions. Under here, you have special pay calculated. Of course, those are those who employ after hours, you know, because it's 24-hour hospital, right? And they have special pay, and that's calculated. Now, in there, it says about $13 million, I believe, in special pay. And then you've incorporated into your staffing pattern and your salary for staff. Does that contribute, that special pay of $13 million, you're putting it in your staffing pattern, but does it accumulate on, does it make a difference when it comes to retirement contributions, when it comes to the total benefits?
Retirement is usually just based on regular salaries and not the additional special pays that we put in that column.
Anything else under benefits that may, other than retirement, like insurance?
Yes, medical and dental insurance.
Right.
There's a life insurance premium as well. We pay.
Is that calculated with the special pay?
No, the special pay is really a separate area where it includes the differential pays for our clinical staff. It includes night differential and holiday pay as well.
Okay. What about
and
your?
CERT pay.
Okay, thank you so much for that. What about your security guards? How many do you have at the SNU unit, and how many do you have at the hospital?
We have about 7 at SNU and about 23 at GMH.
Was that an increase recently on those guards in the last 2 years?
Oh, yes.
It's a substantial increase, correct?
Not really.
Not really? Okay.
We have some admissions. We have some people going as well.
I'm sorry?
Some has resigned. Some has opted to transfer to other agencies that offers them better.
No, I'm talking about a couple years ago. How many guards did you have in place, and then how many you have today is 23, correct? So a couple years ago, how many guards did you have? Security guards?
Right about the same number, ma'am.
23? And then we still have 23 today?
I would say so,
okay.
Yeah.
Lily, how many attorneys did you have in 2019?
How many, what was that?
Attorneys?
Attorney. In
2019.
We didn't have any for many years, and it was just around 2020 was when we first recruited our first legal counsel, Mr. Jeremiah Luther, and then he resigned and relocated off island. But then Mr. Jordan Pauloon, we recruited him about a year ago. 2 years ago, 2 years ago, and then we recently recruited Robert Weinberg a year ago. So we have two.
2 attorneys now
yes,
that you didn't have before. Why aren't you using the Attorney General's office to assist you?
When we were submitting documents to the former Attorney General, it was taking so long for like the RFP and contracts. It was really taking so long. And we've got many other issues such as malpractice issues and questions that the doctors needed some assistance. And so that's why we wanted to recruit, we needed to recruit our own attorney.
So do you need 2 to do that?
It's very helpful. Senator,
yeah.
Yes, it's very helpful to have the 2 attorneys.
Yeah, when it comes time for cutting, we're going to have to find areas that you can cut. I mean, the Attorney General's office is free to utilize them, in a lot cheaper than. So there might be an area to look at as far as that. And before you
Thank
had
you for
actually,
that, but yes,
okay.
He has already given us also notice before that he will not represent GMH. Okay. So. But we
can try
reach
again.
out to him.
Yeah, times are tough these days. We'll try again.
Okay.
When it came to assisting, the Attorney General's office assisted with collections. What is the status on that?
The collections at the Attorney General's office were being handled under the prior Attorney General's term.
Right.
Once the current Attorney General took office, he actually sent all of the files back to GMH and indicated that he wasn't going to handle those anymore.
Have you approached him recently to assist you on the collections? Okay.
No, ma'am, I haven't.
Well, I'll definitely give him a call and ask him if he can assist with that, because collections are huge when it comes to the hospital's concern. Your capital improvement projects, there was one, I know that the HVAC you have here was listed at $3.7 million from federal grants. I know that DOD gave you 2.7, is that correct?
Yes.
Okay, how did you get the other $1 million?
It's the Department of Interior funding that we already have.
Are you utilizing the opportunity to use any of the grant from GURA, the $500 million that's out there? Have you put your request in for that?
Yes, we did. We had an extensive write-up. We had a 7-page write-up actually on the unmet needs of the hospital for the CDBG-DR is what you're referring to.
Yes.
So yes, and I did provide a copy of our submission to some of our senators here, including Senator Matanani.
What is the status of that now? What are you waiting for at this point?
My understanding is that that committee is, they prepared the first draft of the action plan, and for us to apply, it would not be until later on. But in looking at that first draft, actually, we submitted 2 letters. Let me take that back. We submitted 2. One particularly dealing to talk about the need for a new hospital, given our current infrastructure, and the second one related to the unmet needs of our current hospital. Our comments related to the new hospital made it into the action plan.
Mm-hmm.
Our comments related to the current status of our current infrastructure did not, and we did actually point that out to them. We resubmitted it again, letting them know that they may have missed it, but it's there. Because we actually submitted that comment first before the new hospital.
Did they miss it?
I'm just letting you know that based on...
Did you ask them if they did miss it, or just you're assuming?
No, we submitted a...
No, I'm asking, did you ask GURA, did they miss it? Or you're just assuming they missed it and you're trying again?
No, ma'am. I personally communicated with
they
the person in charge
intentionally left
of
it out, is what I'm thinking too, as well.
Unfortunately,
I hope you guys still push on that.
In charge. So
yeah.
It just said that it is in the system, but that it did not make it into the action plan.
Hopefully this will cover a lot of, if we get that, and we can push on our end, to get some of that money for the capital improvements. Also, is there any federal grants in jeopardy?
Just to clarify, though, regarding the CDBG-DR, we were made aware that that will not cover any equipment. It would only be strictly infrastructure.
Right, which still can cover quite a bit. Mm-hmm. Are you having any federal grants in jeopardy right now from these Trump?
Not that we know of. Okay. We don't have any. We haven't received any notice that it will be in jeopardy.
I know this next question is probably silly, but do you have any lapses from FY25 that you inherited? I have to ask. I always ask about lapses, because agencies do this, and I don't want to make them. No lapses at all, so use it. Last question. The tax credits that was given through legislation, I think it was about a couple years ago, regarding defibrillators and cardiac monitoring, that was done to offset, some costs. So has any companies come forward?
Yes, there is a company that's interested. However, what we found out was because of a new legislation that required that the tax credits be included in part of the budget, the FY25 budget did not include the GMH tax credit. And so even though we have an interested company, we're unable to move forward with the tax credit.
So, Senator, to clarify, that was the amendment that I was offering.
Right.
We have the authorization, but there was no appropriation attached to it. So the funds that would be utilized for the tax credit weren't available when the vendor surfaced.
When was that bill put out?
That bill came out in 2021, but since then, the Budget Act never set aside the $1 million to
Well, I don't think there was anybody actually offering to go in. That's what I'm hearing. So now we're at 21, 22, 23, 24, 25. So it expires when?
It expires at the end of 5 years, so it expires next year. And only this Budget Act reflects our first $1 million set aside.
Okay. Well, I have quite a few more. Oh, I got 1 minute and 36 seconds. Okay, let me continue on this. You're requesting is $21.9 million from the Guam General Fund for retirement, medical insurance, and differential pay, but it's really not broken up. How much of that is that coming from? Well, can you kind of break that up? How much is retirement, from the general fund? How much is medical and differential pay? Or is that just an increase to this amount that you're requesting is because your employees increased at Guam Memorial Hospital? You've hired more employees.
The 21.9 is actually the difference between what we calculate as our projected revenues and then the difference between that and what is our projected expenses. So the overall shortfall is 21.9 million.
Okay, so what I'm trying to get at is that if you had your same staffing pattern as last year, so it would be X amount of dollars that would cost more because of the increase in retirement and of course the increase of insurance, of medical insurance and differential pay. Okay. But because you've hired additional, that's what I want to know. What is the difference between new hires in the last year from FY24 or 25, no, 24, a year from now, a year from today, how much is the difference? Could it be an increase of employees versus your current staffing pattern that's been in place since?
The current staffing pattern in the budget request funds all, even the vacancies are funded.
Okay.
So what we're noticing that makes up part of the difference between last year and this year, it's about 5.6 million additional for medical and dental insurance and for retirement.
Okay, I see. So that's different from 21.9 million, right?
Yes, that's part of the increase that we're discussing was for retirement and for medical and dental, but we also have increases in supplies and also for contractual services.
Supplies and contractual. Okay, but all I have is retirement, medical insurance, and differential pay. Now you're incorporating supplies as well in this 21.9?
Yes.
Okay, I see. That's what I'm... Okay, got 2 minutes to go to say thank you so much for what you're doing, and look forward to seeing what we can do to help Guam Memorial Hospital in its need. I think it'll always have, be in the red because of what kind of hospital it is. It's free, basically. But we need to find a way to maybe do a private-public partnership, that we talk... Senator Terlahi had legislation that I think that might be a good help to try and find another avenue to helping Guam Memorial Hospital from not just, getting out of the red, which I don't think will ever happen, but to provide a safe and reliable hospital for our people is first and foremost. We can talk about budgets, but we can throw all the money at you, which we did in the last legislature. Threw tons of money and then find out some of it was not paid, it wasn't handled correctly, and we lost it. Thank you, Mr. Chair.
Just Masi, Senator Taidagui. Senator Gumatauto, you're recognized at this time.
Thank you, Mr. Chair, and thank you, GMH, for being with us this afternoon. And I do have a handful of questions, but I'll go ahead and just try to be as brief as I possibly can. Recognizing that your FY26 budget is based, this is your employee retirement contribution rate. Recognizing that your request is based on an employer retirement contribution rate of 34.80%, what information is available at this point confirming whether the contribution rate will further increase, and if this were to occur prior to the new fiscal year, how exactly will GMHA absorb the additional cost for your employee retirement contribution rate?
Thank you, Senator. Are you asking if the rate goes up?
If it goes up, yes.
Oh, I'm hoping it goes down, but if it goes up, we really wouldn't be able to absorb it. So even with 34.8, it's going up from 31%. So it's a significant increase for us. I really don't know how we would handle that.
All right, thank you so much, Yuka. Let's talk a little bit about the physician contracts, and I was hoping one of your board members was going to stick around for a couple of minutes. But recognizing that your request for contract physicians increased from the last fiscal year, how many doctors does GMHA plan to contract in the new fiscal year? And will these contracts cover specialties that are not currently available at the hospital?
Well, right now, we don't have a neonatologist on board or on island for the hospital, so we're using telehealth, telemedicine, neonatologist services. But if we can recruit a neonatologist, which we are, is in the pipeline, there is an interested individual doctor who would like to come to Guam in August, and so that will be certainly another either contract or GG1 employment for neonatologists. How much?
Just the one, right?
For one right now, but there is another one, I understand, for medical staff who is also interested. And this one is an individual who is locally, who lived in Guam. I think the family is in Guam, currently practicing in New York, and has expressed an interest to come back to the island. So we're hoping that that individual comes back.
Thanks, Lillian. So only one doctor at this point that you guys can proceed?
At this point, one who has already pretty much confirmed his interest and desire to come to Guam in August.
Okay.
Sorry, and the other thing that we're actively recruiting on as well is for OBGYNs. We've had a little bit of success in getting a couple on board, at least temporarily in the locums context, but we are, our medical staff office is actively engaging in that as well. We don't expect, the number of physicians to necessarily change too much, but one of the things we have seen is a number of doctors move from the GG1 to the contract thing, so that's why the contract amount goes up a little bit, because we also hold steady or go down or have gone down over the past few years in the direct employment for physicians category as well.
Okay, so Jordan, you're saying a grand total of 2 new contracts for doctors over the course of the new fiscal year, just 2?
Unless we can get more OBGYNs and those specialties, but those are the ones that they're actively recruiting on. But it's looking like, so Dr. Naomi here is the one that's actually negotiating these. I'll let him actually talk on the specifics with the doctors, but that's what they're doing.
Hi, good afternoon. My name is Dr. Nyame from Neurosurgery, Chief Medical Officer. So yes, we are trying to get neonatologists as well as pediatricians and OBGYNs, and then also psychiatry. We're also looking to get physical intensive care doctors and also radiologists.
So okay, hold on, Dr. Nyame. I'm just trying to get a number of how many you plan to contract in the next fiscal year. So it sounds like right now, I mean, when you came up here, it went from 2 to now, I don't know. So I'm just trying to get a bit clarity. How many do you plan to contract in the new fiscal year?
I plan to get 5 more doctors.
Okay, thank you. That's all I was asking is a number. Okay, thank you. Now, reiterating some of the concerns that I brought up during the oversight meeting from GMHA earlier this year, what information is available regarding the steps that GMHA has taken to ensure that personnel service agreements for physicians are reviewed and approved by BBMR, the Office of the Attorney General, and the Office of the Governor? That's what I was hoping that your board member was going to stick around, but maybe Lillian, you can see how that's coming along. I guess as an update for the budget.
Can you repeat that question, Senator?
Yes, going back to what I brought up earlier in the oversight hearing just a couple of months ago, what information is available regarding the steps that GMHA has taken to ensure that personnel service agreements for physicians are reviewed and approved by BBMR, the Office of the Attorney General, and the Office of the Governor.
Okay. Do you want to answer that, Jordan?
Sure, I can chime in here, but I'll reiterate some of my prior statements from that as well, that we have a different view from the public auditor and the OPA on that, on what what approvals are required for it, because we have broad authority in hiring and contracting physicians. And we've actually even gone back through, based on some requests as well, contracts that, from even 2017 and 2018, and we're following the same procedures that were in place. So what we have now is the hospital administrator and associate administrator of medical services at a minimum are the ones that are approving the contracts. in past years, prior to 2019, there were actually contracts that were even just being signed off by only the Associate Administrator of Medical Services. So we're actually working on a policy specific to physician contracts, if that will actually help clarify things. And we have presented to the board a resolution just clarifying that some of the policies identified by the public auditor don't apply to physician contracting, because one of the approval requirements that he cited to was from our general contracting policy, which is actually specific to materials management, and physicians just aren't materials.
No, I agree with that, Jordan, but I mean, so do you expect the board to see this next month, 2 months, 3 months?
We're working with medical staff. At this point, I don't want to promise you a deadline. I hate making promises that like you're going to see it in a month.
Come on, why not, Jordan? We're all here. We're trying to set your budget, so we're trying to figure out whether they're going to see it in 2 months, 3 months.
Yeah, but we are actively working on it. Even at the last board meeting, had gotten a resolution through identifying the inapplicability of some of the things, and our medical staff is diligently working on that. I've even, on the procurement side, I've put together a team, as I said, to go through it. So we are actively meeting, and even HR meets on a weekly basis, trying to get our own personnel rules together. So we've made more progress, quite honestly, in the last 4 months than we've made in the last 5 years on some of these rules and policy drafting. We really have some people on board that are doing it. The one thing I hesitate with a policy, though, is I want to make sure a policy is helpful for us, so it actually encourages and streamlines physician hiring. There is a tendency to say, get too much bureaucracy, so we could make a policy that actually makes it harder for us. So we're trying to tailor a policy so we have something in writing, but that it doesn't stand in the way for us either.
Okay, that's fair. Again, as we're getting to our budget, I just want to make sure that was ongoing. No worries. All right, talking about facilities, and I want to pull something out of, it's been a while, but based on the facilities condition assessment by the U.S. Army Corps of Engineers that was issued on April 8, 2020, 5 years ago, it was noted that GMH was required $21 million immediately for repairs to support the reaccreditation of the facility and eliminate hazards to health, life, and safety. The repairs consisted of roof replacement, exterior building repairs, HVAC, life safety repairs, and fire sprinkler repairs. So for the record, what portion of your current or for your fiscal year 2026 CIP budget request covers projects from that list that was provided by the U.S. Army Corps of Engineers? Maybe what's been completed and which ones remain incomplete since their findings in early 2020?
So on the fiscal year 26 repair, there is a line item there for hospital rooftop and envelope upgrades. But if you'll notice that it's not actually part of our $29 million request, because if you recall, there was that $15 million that was appropriated by Public Law 36-107, which talks specifically about the maternal child health care renovation, but in line with that, it also talked about another critical CIP, which did include like the roof and envelope. And so because of that, part of that funding will be used to address our roof and envelope project.
So in FY26, you're going to address part of the 2020 report?
Correct. We're actually going to be addressing it part of this fiscal year and going into fiscal year 26.
Okay, and then with that, what information is available confirming the cost difference between the estimates in 2020 from the Army Corps and the budget you need, I guess, now to address any of those unfinished CIP projects?
So if I recall, in the Army Corps of Engineer report, they did talk about the recommendation was primarily to replace, which was a total of, I think, $743 million. And if we were to do any repairs to our current facility, it would actually cost more. I think the tune was $761 million at that time, and that was back in 2020. Given today and all the inflation and COVID-19, cost increases and everything, and in speaking with our engineer, we're looking if, again, this is to address the whole hospital. We were estimating that cost would be closer to $1 billion.
That surety is not on this budget.
Yep.
Not today.
And we absolutely recognize that that's not a request that we can throw on you.
No, of course. I mean, I just wanted to find if there's any of your CIPs are going to touch that report.
So yes, there were things that were addressed. So since that 2020 report, and Mr. Zaldi can speak more on this, but I understand that we did do some roof repairs previously. It's just that the envelope part of it was not addressed, and that's part of what we were hoping to address as part of our, this is a sore topic, but ARPA. But, you know, again.
It might be sore, but you're a hospital, so we got to make it better.
Yes.
So let's see, I mean, Zelda, can you expand if?
Yes, sir. So right now our concentration is more on the HVAC utilities. So we're having 2 450-ton chillers and the cooling towers. We also have the 265-ton chillers. That's including the ACCU. So we're more geared towards the ventilation, heat, and air conditioning units that we need to provide the facility.
All right, thank you, Zeldi. Okay, and I have just one more question, Mr. Chair, and this is to kind of touch back on Senator Taidequi's concerns. With respect to public safety related matters and specific to the budget digest for GMHA's DOC clinic, which did have an increase from 25 into 26. What information is available regarding funding sources outside of the general fund that may be available to cover medical costs for those confined at DOC? And for the record, and based on information that I've been made aware of, what discussions have taken place on the possibility of including this particular population at DOC in the Government of Guam Group Health Insurance Plan?
So I will speak on this because we have not been actively engaged in those conversations, though I believe it has come up as an idea or suggestion at one meeting that we were a part of, but it was not explored in any depth with us because we're not on the health insurance side. So
okay, well let me just start with the first one. Was let's talk about any outside funds for DOC to help address their costs.
I don't have any information on that one. There was a discussion at one point where if these incarcerated individuals are hospitalized in GMH, we can get them under Medicaid coverage, but public health director says no. So they're not at all entitled to any insurance coverage, but be it federal or be it private. They're not eligible.
And why I ask about the latter relative to the GovGuam health insurance, because it's part of the RFP process.
I have
Does
no
anybody
information
on
that one.
on this panel, can they explain that one for me publicly?
I'm sorry, I don't have any information on that one. I'm not part of the discussion.
All right, thank you so much, GMH. Mr. Chair, thank you for the time, and thanks for allowing me to ask questions today for the GMHA budget.
This is my seat, Senator Gumatauta. Senator Chalahi.
Thank you, Mr. Chair. Thank you to the panel for your testimony today. So in your presentation, it's different again than last year's presentation where I think it was Dr. Prinz gave us some breakdown of what the funding gaps would look like in actual services. And I know Yuka, you read, Ms. Echanova, you read off a list of what those would be, but they're not really tied to amounts. So it's very hard to compare, I guess, this to what they were asking last year. So you're asking for, looks like twice the amount of an increase than what the governor was asking for in her budget request or allocation for GMH this year. And it looks like not included in your budget is this whole list of CIP projects totaling, what was it, $29 million in CIP projects, and then that's not even, you don't intend to go through of any of these CIP projects with the budget requested amount. Is that correct?
The CIPs were presented separately, so we wanted to break down what was operational and then what was CIP.
All right. Do you intend to pay any of these or go forward with any of these CIP projects with your operations funds?
Some of those projects have already been started and we've been invoiced. So when I presented the accounts payable earlier, I highlighted one area around 2.8 million, I think. That's the amount that we owe for CIPs right now that we need to pay vendors.
All right, that's past though, right?
Yeah, that's for, or ongoing, I believe.
Right, but we're talking about for 2026 budget? Yeah, are you intending to use any of your 2026 budget for these lists of CIP projects that you've given us that total 29 million?
No, ma'am.
Okay, so you're looking for alternate sources of
Yes.
funding for the 29 million. Have you had this discussion with the governor? Is there any alternate source that is being proposed?
As Rodolin explained earlier, we've been exploring the different types of grants that are out there, working with GMHA and what have you. We also, in our meeting with the congressman and his staff, we asked them to help us look for funding opportunities as well. And I think they recently did throw something at us. So they're also actively trying to help us find, whenever we're looking for grants, they always seem to, we don't qualify. They really help for preventive care, public health type things, but we're having a really hard time finding grants for hospital operations and CIP. So they're helping us look for those kind of grants as well.
All right. Yeah, so I don't think these were included in the governor's budget either based on her numbers. Hers are, she's asking for half of the amount you're asking for in operations, and none in CIP. So the CDBG-DR, that's, I'm glad you applied for that. I'm glad you're reminding GMHA that they forgot to put yours in their list of urgent needs. But that, my understanding of those hearings is we're lucky if we can come out with a project in 3 years. So, but your projects look more urgent than that, and we hope to be out of this hospital by 5 years at minimum, or hopefully. Anyway, so I'm not sure what you're going to do about that. Can I just ask about this electronic health records, 14 million? I heard you describe where you got this estimate. That is just a preliminary number, but that seems very far too low. And yeah. Do you intend to use a consultant to procure this?
So if I may explain, in previous oversight or legislative hearings, we have estimated that our EHR for a 5-year period would cost us about $60 million. That was an estimate based on previous research that was done. Now, given that $60 million is a lot to chew on, and let alone, I mean, even $14.5 million is a lot, but we have to start somewhere. And so we were thinking, at least for presentation purposes, what we're asking for is, at least for the first year, and we're estimating about $14.5 million, just knowing that the reality is that if we are to procure an electronic health record and any IT system, usually the upfront investment is higher than in subsequent years. And so given that, that's the reason why the estimate is at $14.5 million for a new EHR. But again, as we've said, this is just an estimate. One of the things that we are working on, of course, like we mentioned, was that IT risk analysis. And then we did receive, I believe it's $96,000 on the BEAD, the broadband equity funding. And with that, we are to do an IT assessment with that funding. And so we currently have a draft RFP for that IT assessment, which we're hoping to push out soon. We just need to make sure all the requirements that's in the agreement with the grant is in place before we push out the IT assessment. So what the hope is that the risk analysis together with the IT assessment, the results of that would help us in further refining the RFP, the draft RFP that we do have on the EHR. But again, the challenge that we have is even if we have the draft RFP, we can't push it out into procurement without any kind of funding source. And so here we are, and we're trying our best to see, again, however which way, whatever funding is available, we're trying to get grants. We were working previously even with Homeland Security Office of Civil Defense, because our understanding is aside from the hazard mitigation grant program, there is also, I believe it was a cybersecurity grant. So we were hoping to try to get that. We did actually submit a grant application on IT infrastructure back in, I believe, 2023. We were informed at that time that it was going to be submitted as part of the cyber security funding, but each time we followed up, there was no response on that. And so again, we are really trying actively, however way we can to identify funding source for these things.
All right, I just want to make sure that we're going to procure correctly what we need and not have an error that we talked about before. So what about, are you going to use a consultant for that? Or you're saying your risk assessment, your risk analysis IT assessment is what you're going to use to procure the electronic health record?
Where we're going to use the information that we get from these documents. So right now, as we mentioned, the IT risk analysis is the one we're going to submit by today. And
are you talking about an analysis or an RFP or something for it?
No, it's an actual analysis.
So it's done?
Yes, it's done, and it's going to be submitted today. That's the one that we're going to submit to HHS, Office of Civil Rights. That was the requirement that we have. It's due on May 7th, but we're going to submit that early. But in addition to that, we need the IT assessment, and that we need to procure. So for the IT assessment, we're going to use the $96,000 that we got in the digital equity grant funding to procure that IT analysis, the IT assessment. And we're hoping that these documents, the results of these is what we would use to further refine the current EHR RFP draft that we currently have. So that way we can procure the proper system and not just whatever.
If I may, Senator Talani, the HHS OCR risk analysis has looked into our threats, our vulnerabilities with regards to our IT system. And so that can also help us determine what hardware, what software, and what other training we need to make sure that we enhance the cybersecurity of our IT system. And that can help, but the IT assessment from the digital equity really focuses on other aspects in terms of our IT infrastructure and processes.
All right, because it was my understanding that if you do not have a consultant in regards to specifically an EHR, I just questioned that, because that's the issue that we had the last time. I mean, anyways, can we see copies of these reports, the risk analysis that you're submitting to HHS today? And
so we're submitting it today, and then we need to wait for feedback from HHS and a revision. But once it's finalized from HHS and we have the final report, yes, we can share it.
When is that?
They have 60 days from the time that we submit to review and then give us the feedback whether or not we meet whatever the expectations are in terms of that analysis.
All right. Have you received any input from the consultant that Gita hired in regards to hospitals as to your EHR needs?
Yes, we've been meeting every week, giving him information as he's requesting it, and then discussing some areas where we want him to help us improve. We started with the revenue side, and it's pretty much concluded on what we just discussed today, that the private payers, if they don't pay us, we need to sue them. And that's exactly what we want to do. We just have to sue them. And then with the Medicare and the Medicaid and all of that, of course, we need to explore options on different payment systems, either rebasing, critical access, that type of thing. Then we move into the cost containment and expense area. So we're starting right now with the highest cost, which is personnel. And so we need to see what areas we need to cut or move people around, and how do we optimize our staffing with our functions right now. And then we're going to move into contracting and supplies, procurement, those types of things.
Well, I'm glad you're consulting with him. I'm sure it was part of his job to get information from all the government agencies. My issue is you've known all of that all this time.
Yes, ma'am.
Particularly, there was a couple things, this need for the EHR. Your list of CIP does not even include the maternal child health. Is that off the table now, or the envelope?
It is there.
Where's that?
On the schedule that was provided to you, it's on the top portion under structural and architectural projects, maternal child health project. It's the second to the last one on that first table. For FY26, we budgeted $3 million. It's there on this spreadsheet.
What about the MRI building?
This one?
Okay, I don't know what that document is. I'm looking at your presentation today, so it says it's not on this one.
And the reason why it's not on there is because that slide was specific to the $29 million for FY26, but because we are using the Public Law 36107 for the MCH, that's the reason why it's not on that particular slide, ma'am. But
Well,
there is a separate...
So are you proceeding with it?
We need to still go out and do the IFB again.
All right. But
yeah.
Did you get the money?
That was the Public Law 36107.
Did you get the money?
They're not going to...
Because that was in place for a very long time, and then you said you were going to use ARP funds for that, and now we're going back to, and I remember at the oversight hearing you said you're going to go try to get that money again. So is that secured? These are promises made years ago.
Right.
Yeah.
But we don't have access, or we don't have control to whatever was been. It's GOA who has that and BBMR, so we're relying on them.
So are you able to go out with an IFB based on that?
Yes, because that was an appropriation.
Yeah, so what is this paper?
That is...
Because you didn't present on this today.
I did. When I was presenting on the slide, I did say that there was a separate printout that was provided. When I was presenting on the CIP slide, I did mention that we provided a separate printout, which was in line with what was provided when we initially submitted our budget requests. And so on the budget request, there is a tab specific for CIP, and that was in there. The difference is that we just color-coded this one, because the one on our the budget book is not color-coded. So that's why we...
So how are those projects going to be done? You just finished telling us these projects cannot be done with the budgeted request for 2026, and that they were not budgeted in 2025, right? And the ARP funds are gone. So are you saying you have additional CIP projects that are what? What is the status of those? Are they going to be included in your FY2026 operations budget?
So for the specific...
Are they?
Well, specifically for the maternal child health, there is, like I mentioned, the Public Law 36107. I believe it's Chapter 12, Section 53.
I'm familiar with the law.
Yeah.
So what's the status?
So the last time
No, I know you went out for bid and you got no offers.
And so we needed to go back. Before we put it out to bid again, we need to go back to revisit the scope because based on the feedback we were getting from those that were interested in, that actually picked up the IFB, some of the comments we received was the project was too big. And so because of that, we needed to go back to revisit the scope. And so that's where we're at, revisiting the scope.
What was your funding source at that time? When you put it out for bid?
For the MCH, Public Law 36107.
Okay, because in the oversight you said you're going to have to pursue that to see if it's still available, right?
Yes.
When this accounts payable, have been receiving complaints about this accounts payable. So it's 20 million now, but 2026, is the 2026 budget going to this, or this is just some extra information you
Because
wanted
this
us
is
to
the
know?
current payables
Yes.
as of today. Yeah,
Right.
the 2026 budget is supposed to show what we're going to be, our expenses
Right.
will be in 2026.
Okay. So what is your plan to pay these? Because, and some vendors are asking, well, first of all, it's concerning because the largest expense here is pharmaceuticals and supplies.
Yes.
And I heard some of the board meeting the other day where they're talking about the I think it was you, Lillian, talking about the hardship on the nurses and those who are receiving care about this lack of supplies. So what is the impact of this accounts payable on patient care, and what is the plan?
What was the last part of your question, ma'am?
What is the plan? Have you discussed this with the governor? There's 20 million accounts payable, over 9 million, that's over 90 days payable. Some of the vendors are telling us that they're not sure they're being treated fairly. Well, some projects are going forward, some are not, some including CIPs versus paying off the supplies and the other goods. So, yeah, what is the priority here? How do you pay the priority? And how do you prioritize the payment, I guess? And if these are over 90 days and we gave you 20 million, and then they took 10 million for accounts payable from the ARP, these over 90-day ones were not paid at that time. What is the plan to pay these off?
That's a very good question. I ask myself that every day. It's been very challenging with the cash flow issues. The priority has always been payroll. So this week it's payroll week, so we're prioritizing collections to make sure that we can pay the employees. With the vendors, we try very hard to pay them, but in most cases, we try to arrange payment plans. If we owe them $500,000, we negotiate. Can we pay you $100,000 today? Maybe next week we can pay another 50. It's easier for us to pay if we can break it down, but there's just not enough cash to pay all of these payables. It's been very, very difficult. We had the 20 million that we got back in October. We used that immediately to pay vendors, and then we had some left when we had to start paying for some of these CIPs from the ARPA fund, the former ARPA funding. We were using that money to pay for it, but now I think now there's about $50,000 maybe left in that 20 million. It's been exhausted. So we use that 20 million to pay for vendors, but also for the withholding taxes, insurance premium, even for payroll stuff too. We use that to pay off those vendors. Then we used to pay suppliers, and then the last part of it we used to pay off for the CIPs.
Are you talking about the 20 million that DOA transferred to GITA? Or another 20 million of ARPA funds?
No. We had a 20 million supplemental appropriation.
Yeah, that?
Yeah,
but then you
that
start
one.
talking about ARPA funds, I thought.
Well, because some of the projects earlier that Rodolin was talking about were funded originally from ARPA, and then when the funding got moved, we were already had obligations where we had purchase orders and contracts already signed, and some even the invoices already came in. So as another source of funding for that, we still have about $3-4 million left in that $20 million funding pot that DOA is holding. They're the ones paying the vendors for us. We send them the invoices and they pay the vendors, so we don't have the cash.
From the 20 million that we appropriated?
Yes.
Okay, so,
yes.
But then they also took 10 million of the 20 million promised from the governor for CAP projects. They took 10 million to pay for vendors, they said. But none of those were these vendors here? I mean, obviously, they didn't. We still have over 90-day vendors, $10 million.
Yes. Yes, we're supposed to pay them with our ongoing collections.
So when they took the 10 million, there were more than 10 million in vendors payable at that time?
Yes.
So,
yes.
And they just took the rest of the other 10 million and gave it to GIDA instead of paying off more vendors. So what is your plan? Because the vendors are very concerned about this, and I'd like you to tell them directly by this hearing, what is your plan to pay them? What should they expect? Because a lot of them want to stop services to the hospital.
We would like to get the funding from the pharmaceutical fund. So I did an analysis going back to 2019 of the BPT and the performance and how well it has been doing, especially in the last 3-4 years now. And what Jordan had talked about earlier of what some legislation that would help us, and this would not even be a new funding source or nothing from the general fund. It's something that rightfully is supposed to go to GMH, is 6.19% of the BPT, but we're only getting what was appropriated in the budget acts.
Right, well, we could also take the extra 30 million and say that that came out of the BPT because it's coming out of the general fund, right? We're also giving you general fund monies that are coming from a combination of BPT and other sources. So that's just almost a semantics thing, but I understand. But that's not a solution for these vendors, right?
And one of the things that's been happening with our collections now is we're only getting 50% of our Medicaid reimbursement because of what DOA is keeping half of that to pay what, when we borrowed from the Medicaid, we got an advance when we shut down in 2023. That has been paid off, but they're still recouping for an advance we got from the pharmaceutical fund earlier this year of $5 million. But if we have extra in that pharmaceutical fund from the 6.19 BPT and we can offset things like that, then I think the main thing that I want is cash flow. And if we can get the full Medicaid reimbursement, that's going to be $1 to $2 million a month that we will get in cash to pay vendors.
So what is DOA's response when you, I'm sure, plead with them that this is your status and that they're supposed to be the fiscal review commission for the hospital?
Yes, I did send the analysis last week, and I didn't get much feedback, but I will follow up this week to see if that's going to be a possibility. And the whole goal of it really was just to make sure we can get our Medicaid reimbursement back to get cash flow going again.
What is behind this denial of physician professional fees for providers with private clinics? That you're saying the insurance companies are denying fees that they didn't deny before?
So this is one particular insurance company, as it's on your slide there. What's happening is we have an outpatient clinic that serves a higher risk population, typically speaking. And like most other hospitals, we can charge both a professional fee and a facility fee, which the cost of seeing an outpatient in a hospital is higher than it would be in a private clinic. And all of the payors have been paying these claims and have been pretty diligent in it. I think with the rising costs, though, one of the insurance companies has begun to balk at that. And then because the insurance company then also has agreements with physicians that might also have a private clinic set up, so they'll see the acute care patients in the hospital and then go see the outpatients in the clinic. The insurance company is asking us to actually bill the professional fee in the outpatient clinic, with which we have no relationship, even when it is a patient that's been seen at GMH. And so we're having ongoing discussions and negotiations with the insurance company about that, but Yeah, we believe it should be paid.
Is this related to the auditor's audit on physicians that are serving in both capacities? They have their patients in out clinic, and then they have their patients in the hospital that they also are getting paid for, things like that?
No.
Is that what they're objecting
No,
to?
what they're objecting to is strictly the rates that are being charged. And these are rates that we've set through the AAA and we've received comments on and things, and almost all of the payors are processing them and approving them in the EOBs. It's really this particular insurance company that we're having ongoing discussions with.
Okay, well, the other thing is this, well, I mean, I wish you this success, of course, in your critical access hospital designation. It's just, this is something that we've talked about again for years, and it's like we're just beginning to work on it now. That's how it sounds today, and that can't be right, but it really is how it sounds. Same thing with these rebasing of the rates. I know you've been waiting for DOA, and then you're saying you need to hire your own consultant because DOA's consultant is just not giving you what you need fast enough. I don't know what's going on between the hospital and DOA or the governor, but it just seems like there is a gap of what you believe is urgent and that you are unable to pay and the needs that you're unable to meet, like, for example, vendors and supplies versus what DOA sees and why they are withholding money, like the Medicaid reimbursement or these reports or consultants that would help you to get the rebasing. We're way behind in these things and in trying to mitigate these costs at the hospital and so all of these things together, right? I mean, of course, yes, you're taking care of patients, and we are trying to appropriate to cover patients that are not being paid for in any other way through Medicaid. Private insurance is not paying their full share. If that's the case, we are also trying to subsidize those. We're trying to subsidize all kinds of things, but yeah, but also, you know, the efforts, this is an urgent situation. It's I thought, emergency a long time ago, but that we're just going to work on certain things now it's just, I don't know, it's very concerning, and it just seems like DOA, the governor, and the hospital are not on the same page as to the current needs, whether they are urgent. We have increasing personnel expenses, not just physicians, but non-medical related, and that's why I sent you a FOIA regarding the above-step recruitment of non-medical. We have 2 attorneys where years ago I would meet with you, and it was very clear. You were telling me the Attorney General's office is handling all our collections. We didn't even need to go to an outside collection agency at one point because everything was taken care of. And now, I don't know, it just seems like everything's gone backwards. We have an appropriation for maternal child health. We're still waiting for that rebuild, I guess.
May I comment on that?
That's not listed here on this list again, and I guess it's confusing to us. Or we're supposed to refer to this now as to what are the urgent CIP needs. This is not it. You're saying there are others that are more urgent on this other list as well? Is that what we're supposed to do?
Senator, your time's expired, so that will be your last question. Thank you.
If I may comment on that collection, yes, the previous
yes, please,
Attorney
proceed.
General was helping us, but the current Attorney General is not helping us on the collections.
That's because you hired 2 lawyers, right? That was
No, that was even before.
Senator Blas, Speaker Blas.
Thank you very much, Mr. Chair, and to the panel, thank you very much, for being here. I'm going to start with this. There was a discussion with regards to DOA holding back your money. What is your total amount of how much DOA is holding in your behalf or have not given to you?
I think currently we still owe about 7 or 8 million for Medicaid advances. So they're keeping 50% of whatever our Medicaid reimbursement is. So for example, this week, our Medicaid reimbursement is supposed to be $1 million. We'll only get 500,000 because they're keeping the other 50% to pay off what was advanced to us.
Paying off who?
DOA.
So they're holding back your money to pay their bills.
Because they advanced the money to
It
us.
doesn't matter.
So
Yeah, I mean, I can trade off another agency with yours and hear about reimbursements that have been unauthorized that they paid, and they're not asking them for reimbursements, but yet they're asking you for the reimbursements.
yes.
Okay, so you're looking at about $7-8 million. Interestingly enough, that's about the same amount of money that other agent they flooded for that other agency, and are not requiring for them to be paid to pay back. Okay, I just find that interesting. You know, earlier you talked about you're hoping that the retirement rate doesn't increase to 34% from the 31 you do. If that were to come into fruition before the end of the fiscal year, what are you going to be short on? How much are you going to be short to be able to make the payroll?
For this fiscal year?
Just for this fiscal year. What are you looking at?
Right now, our challenge has been meeting the obligations for the health insurance, dental insurance, and the withholding taxes. We've been able to maintain, all we have money left to do is pay retirement. And so we've been paying retirement on time, but there's just nothing left to pay the withholding taxes. Withholding taxes, every payday is about $430,000. Medical and dental insurance is about $450,000. So every payday we're short about $800,000 to $900,000 to pay those two obligations.
And that's at the current rate.
Yes.
And what if that rate were to increase now? How much more is that going to impact you?
If the retirement rate goes up next year, it would just depend on the percentage. Right now, it's projected at 34%. Yeah. So if it goes up to 35, that's another percentage point.
Okay, let's just hope that it stays at 34, even at that. You don't want to hope for that, but what is that going to mean as far as impact?
We would definitely have to recalculate our staffing for that. And I understand a lot of people move to the new retirement plan, and that's definitely the reason why these costs are going up, because we noticed it since last year, and that's when a lot of people moved to the DB plan. So. And
that wasn't factored into your budget request?
For 2026, yes.
It was?
Yes.
34, up to 34%?
Yes.
So what is that delta? What that factor, how much did you factor in?
It's about $3 million more.
Okay. You know, before I even go even further here on your budget requests, there's about a $21.9 million delta between your request and what the governor's office had requested. Is there any discussion with the governor's office as to why there was such a huge disparity in what you're requesting for and what the front office says that you can live by?
Not in so many words. I think the problem is they submit their budget way ahead of when we finish our budget. So our budget is done by the end of March, and I believe they submit theirs in January.
So have you had a discussion as to where they came up with just $21 million? Or
I think
$28 million?
They used last year's appropriation and added another 15 million, I think.
Your last year's appropriation was at 33, and they went down to 38, to 28.
For the general fund.
That's what I'm reading here.
So the 21.9 was not factored into the executive budget.
Your FY 2025 authorized level was at 57.7. Your governor's request for FY26 is 53.89. So that's not an increase, that's a decrease. Anyways, well, is there any answer for that? I mean, obviously your costs, healthcare is supposed to be a priority here, and your costs are supposed to have been increased. I can understand that, you know, it doesn't even take into consideration organic growth. If you were to, based on authorized levels from the previous fiscal year.
We have about, I think, 900,000 on salaries alone, just for increments and things.
It's that doesn't take into consideration. So I'm just wondering, I'm trying to reconcile, okay, what you're asking for and what they provided, and recognizing even though that your budget request came in a couple of months at least after theirs, there should have been some discussion and a little bit closer. I wouldn't have been a little more comfortable if it was just $6 or $7 million in as far as difference, but this is $21 million. Not inclusive of, and I noticed your footnote 1 here is basically, it provides the $20 million from Public Law 37-135. Make me understand why this footnote exists here. Is that inclusive of the $50.4 million request that you're asking for? Where does that fit in?
No.
So where does that fit in?
Are you talking about what's on our presentation?
Yeah, it's on.
Oh, that one.
Yeah, this one.
That one was prepared by
that's OFB.
Finance and Budget.
This was prepared by what? I'm sorry?
Office of Finance and Budget.
This is prepared by Office of Finance?
Yes.
Okay.
This is not prepared by us.
So, Mr. Chair, what does the footnote 1 mean here? I'm trying to figure out where does it fit in as far as the numbers.
Yeah, so footnotes are essentially what is the variances within the request and what happened in the prior fiscal year or current.
So that I can understand this, is that footnote 1, $20 million, is that factored into the 50?
No.
So where does it fit?
It's not. It's just recognized that was additional appropriation.
Okay. Even at that, even if you were to factor that in, it's still over $10 million in delta between your budget and your budget request and the governor's budget request. Okay, well, I'll get back to that later if I have time.
Yeah, if you look at the total variance actually between the governors and it's actually 52 million. Yeah.
Okay, appreciate it. Let me talk a little bit about your CIP request, $29.3 million. Okay. Are any of this hazard mitigation projects that have been tentatively approved, or there's some life to it?
The removal and replacement of the main electrical distribution panel, sub-panels, and emergency generator, that was initially part of our application for the hazard mitigation grant. The total amount is actually closer to 16 million, if I recall. But because we planned this out as part of our 5-year CIP plan, the first year is that $5,160,000. Our understanding in recent discussions with Office of Civil Defense is that our HMGP application was not eligible, which we were still inquiring with them as to why, because this particular project was part of the state plan, hazard mitigation state plan, and so we're still trying to inquire with them, clarify as far as why they're saying that our project is now ineligible for the HMGP.
Is it a matter of it not being eligible, or is it a matter of, from the word I was getting is, they just haven't been able to get to it? remember when we had the meeting, and I
Yes.
said, I'm going to look into it.
Yes.
And the word that I was getting is that they haven't even come to a decision on that yet.
Okay.
So, you know, I mean,
Okay.
Okay.
So it's still possible then.
so, okay. So I'm
Thank
going to
you.
get back to that, okay?
Thank you, Speaker.
Okay, I'm going to get back to that. Next one, your workforce reduction that you explained, I guess, in your presentation about how you're going to be able to reduce things. And it's kind of interesting, okay? You worded up to 10%. All right, if you were to go with your workforce reduction of 10%, what is your total cost savings in that?
It'd be about 13 million.
13. As opposed to a salary reduction of 10%, what would that cost you?
13 million.
13? You have $14 million here. Well, 147,980,000. 10% of that is 114,980,000. Right? This is an option, okay? I mean, hopefully you don't have to get to that, but you know, that's where it's at. But what are your total cost savings if you were to implement, I mean, savings if you were to implement all your cost saving measures? What is your total on that?
I think we've come up with a little less than $10 million so far on cost reductions, and there's definitely a lot more work to do as far as reviewing all the contracts we have to see if we can renegotiate rates. But initially, it looks like it's going to be about 8 million.
Your total cost savings?
So far.
You just finished saying that if you went to up to 10% of total of payroll reduction, it's going to cost you $13 million.
Then it would be 8 million plus the 10% workforce would be 21 million.
21 million?
Yeah.
Okay. Okay. There was a discussion earlier too about your TEFRA and your rebasing. And that's been an ongoing discussion. I remember back in the old days having that discussion with Dr. Larry Lizama. What seems to be the holdup with regard to why we're not getting better rate?
It's really because of the way GMH is classified, along with the Virgin Islands and CNMI, where we're the very small group of hospitals that are left that are under this TEFRA reimbursement model, which means they pay us based on a cap for a discharged patient, which is right now significantly lower than our actual costs to discharge this patient. The other hospitals in the mainland are paid on the inpatient prospective payment system, which is based on the patient's diagnosis. So if you're going in for a heart-related procedure, CMS will reimburse this amount. It's already a fixed amount, and they get that amount from all the data from across the country, so they decide, okay, this is how much we're going to pay for this procedure. For those hospitals, too, it's also, of course, they get paid below what they actually expect to get paid. We're all in that same boat. But for us, it's particularly alarming because now our costs have gone up so much more than we expected since 2020. So when I look at the annual cost report we do from the year 2014 when we got the rebasing, that differential between our actual reimbursement and the cost that it takes to take care of that Medicare patient, it was from zero in the first rebasing year, and then it climbs up to $1,000, $2,000, and it stayed like that until 2020 when it shot up to $10,000, $14,000. Now we're at $14,000, $15,000, because the costs have never come down from the pandemic.
Understood. What is the TEFRA rate for the CNMI?
I can't,
think it was-
I don't know.
Last time I remember hearing, it was obviously considerably more than what we're getting.
Not considerably. I think it was maybe 2,000. I know the Virgin Island, I think, is 1,100. The last time I talked with the CFO there, he was saying $1,100 for them. So they're having the same issues that we are. So that's why it was important to meet with the congressman, because if this can be fixed at that level, it will also impact other hospitals that are in our same situation, that are experiencing these cash issues because they're not getting paid enough from Medicare.
Okay, well, if I remember correctly, I think CMI's rate was closer to 2,300.
Maybe 2,000?
I think it's 20. Oh, that's all right.
Yeah.
Okay. It's just, I'm just wondering, what is the stumbling block from what you're hearing, and how do you intend to fight that, or how does the congressman intend to justify an increase? What has been the discussion on that?
There is a process. So CMS has their own guidelines on how we get reimbursed and how we need to go through asking for these adjustments and even for rebasing. So there's an extensive study that needs to be done to show, basically to show what the justification is. Why do we need to get that increase? Yes, we have more costs, but why do you have more costs? Are you providing more services? Are your patients sicker? Are they staying longer in the hospital? There's just this list of things that you have to go through. So what was helpful in the past was the consultant from this company called EOP had put all of that together, and then that goes for the CEO's signature at the hospital, and then it's sent to CMS for their consideration.
And did I hear that correctly? DOA had hired a consultant to be able to work with on your rebasing?
That's what we were told.
That's what you were told. So, but has there been any discussion with this consultant? Where are they getting their information then from?
Well, I was told to send 10 years of the Medicare cost reports to them, and I did.
I can
sent
send you 10 years of reports, but if I can, and ain't nobody there to help to explain what it is,
yeah, we just haven't had any feedback.
Okay. You also mentioned mentioned that you had requested through GURA for basically consideration in CDBG grant. What specifically, what was the ask? How much were you asking for, and what was the ask?
For the CDBG?
You're right.
So we actually submitted, because our understanding when we were to prepare the documents is that we didn't necessarily have to put an amount. We just needed to talk about what our unmet needs were.
What are your unmet needs based on your CDBG?
So part of it was we talked about, sorry, let me try to see if I have a document here. We talked about, again, the infrastructure damage and deferred maintenance related to our current facility, the electrical infrastructure, specifically talking about the main electrical distribution panel and so on. We talked about the emergency power deficiencies and load banking need, the replacement of our aging fuel storage tanks and the provision of a protective shelter, the influx of our social case patients, emergency preparedness infrastructure gaps, particularly dealing with the lack of on-site helipad in the case of an emergency that needed a helicopter transport. Limited mass casualty capacity, inadequate morgue space, lack of alternative care sites, the Z-Wing retrofit project, and being able to expand our clinical capacity. Yep. So we talked about a lot.
Almost. Okay, thank you. Appreciate. What has been? Give me your best guess estimate as to what, recognizing that this is what, half a $1 billion total grant. What is your best guess estimate as to what you're asking for? Not only what you expect to receive, what you're asking for. The best guess.
I would say 20 million.
20 million for all of that?
For all those that we just mentioned.
CBDG?
Yes.
Actually, I would say more
More than that,
because
right?
just the main electrical distribution panel, as I mentioned, on the HMGP is about 16 million.
Okay. When did you turn in that request?
I want to say April 17, April 18, somewhere there.
Okay. It's interesting because I got a copy of a letter that you guys sent to CBDG, to Gura,
Yes.
asking for the money to go towards the design and to pay for a new hospital?
That was the second letter. So there were, like I mentioned, there were 2 letters that we submitted to, for the CDBG DR.
Yeah, but in your second letter, you basically write language in here that would basically nullify your first letter and all the... Remember when I said I was going to get back to your hazard mitigation request?
Mm-hmm.
Your second letter appears like you just threw the rest of that stuff under the bus, in that you basically state that FEMA has denied you for reimbursement for pre-existing conditions, and it rejects your proposed mitigation projects due to the facility's aging conditions. I'd be very wary, because then if I was looking at both letters, I'm going to say, what do you want? And guys, it's going to be, again, we want to help, but don't shoot yourselves in the foot. Yes, we need a new hospital, but we've got to also maintain our current one. And let's not throw our current hospital under the bus for a hospital that we want to be able to rebuild. Okay? And I'm sitting here over the last few hours listening how we need to be able to sustain a hospital, but I'm looking at a letter saying I want money. If there's anything, I want money to build a new one.
Well, sir, part of this is, I think a week ago we had some visit from Homeland Security, and they came to visit our facility, and that's what they're saying, yeah, deferred maintenance. So we ushered them to our power plant. So I told them, how could it be a deferred maintenance when we still have all these antiquated systems and equipment still running to date?
Uh-huh.
So they were not able to answer me on that question.
Well, yeah, and I appreciate that you're forthright and honest about that, the whole thing. But again, you be very careful on what we're sending, because April 17, you're asking for close to $100 million in monies to fix the hospital. In April 18, you're just saying, you know what, let me have money for a new hospital. Okay, so I don't want to belabor that, and let's just stick with, okay, but it just strikes me, please guys, we want to help you, but you got to be very careful as to what we're asking for.
But that was what the FEMA gave us, informed us that they were not going to support what we requested, because those were pre-existing conditions prior to MAWAR, and that was what the disaster recovery CDBG application that we submitted.
Understood. I understand all of that, but in the meantime, you have another project. You've got submission for other projects. You just admitted that you said that you submitted your CIP projects through hazard mitigation, and there's still a discussion on it. You have to give yourself time to be able to finish those discussions before you throw everything under the bus and then decide to go down this road. Thank you very much, Mr. Chair.
Thank you, Mr. Speaker. Kind of hard to tell you your time's up. So you were right on time. Senator Will Parkinson, you're recognized.
Thank you, Mr. Chair. I just have a few questions about a couple topics. So I just want to talk about the urgency of capital improvements a little bit. I see here that there's about 40 million in 2026 capital projects. The Army Corps has found that the physical plant of the hospital is in an overall state of failure. The roof is aged beyond its useful life and is compromised at this point. Given this context, can you explain how the funding of the $40 million will fund these critical issues, and why now? Why should we dedicate this money now? Make the case for us, please.
Given that a new hospital will likely not be available for us to move into for another 5 years or so, we still have to maintain the current facility. And in doing so, part of it is to address these issues, particularly dealing with the roof and envelope. If we don't do it now, and we've said it before in previous testimonies, that we don't know if our building can withstand another typhoon. And so we have to still address the current hospital because we still have patients that we need to take care of. And if we don't have a facility, how are we going to take care of those patients?
Thank you for that. And I guess my other question is under expanded capacity and emergency preparation, I note that there is 3.8 million for that offsite preparation. What can investing in that offsite preparation get us that investing, like why don't we just invest that 3.8 million directly into the hospital itself? What is this 3.8 million offsite buying us that it's not buying us on site? That's 800,000 allocated to upgrade the skilled nursing facility and 3 million for redesigning the maternal child health, the NICU department.
Oh. So because GMH is the only facility that takes care of our maternal child health, so these are our pregnant mommies and their babies. Again, same argument, because if we're not gonna see a new hospital soon, we still need to take care of our current patients. And the common criticism and issues that we've been having is that our current NICU can only house 4 babies. And so part of this project was to expand our NICU and the nursery and the likes. And so hence the reason why it's important that we take care of it for this current facility. And then for the SNF, that is related to the server room upgrade. So the current server room of our SNF is currently undersized, and the SNF serves somewhat of a backup for our IT. And so we need to make sure that, again, it still speaks to our IT infrastructure, but particularly dealing with the offsite. And so it's still important to us because if our system goes down, we need that backup site.
May I add something there, sir? Sure. As far as the MCH, we already have a ready shovel plan. So all we have to do is just bid it out. We did try that, but unfortunately, there was no takers at the time.
All right, thank you for that. I want to talk about operating losses. We're nearing about $31 million in operating losses, double from the prior fiscal year. It seems to be that there's a trend that costs are up and revenues are down. Could you please paint a picture for what's driving this trend?
As far as revenues are concerned, we do have reimbursement issues from Medicare and Medicaid. I also explained earlier that some of even the private insurance companies, we have delays in payments from them as well, so that hurts our cash flow. Expenses have been rising in the last 5 years since the pandemic, mainly for personnel. We've had pay plan adjustments for nurses. We did that twice. We have the general pay plan. We had also for law enforcement, our security are classified under there. That was also adjusted. So we've had 4 pay plan adjustments in the last 4 years. And in addition to that, to retain and recruit nurses, because that's been one of our biggest issues, is we've had to offer differential pays of 25%. So when the nurses are working, they get a 25% working differential. And these efforts have helped us retain nurses and recruit. The turnover has gone down, so it's worked, but it's also very expensive. And at the same time, the cost of supplies have really gone up astronomically from before the pandemic. Now we have talk of, I'm not sure what the impacts are right now, but if there are tariffs that will impact the pharmaceuticals and our medical supplies, that's going to be another issue that we have to deal with if that happens.
What about the role of the deteriorating infrastructure? What role does that play in increased cost or lost revenue?
Well, almost every day there's something to fix. We constantly change ceiling tiles. The elevator goes out once in a while. The chillers constantly need maintenance. I mean, there's always something to fix because the facility is old. And some of these fixes are things that we did not expect to happen sooner than later, but they have to be repaired right away, or somebody will get hurt. So that's a priority as well, as we need to get work orders and supplies, and then the facilities maintenance people will usually go in and fix what needs to be fixed that day.
It is, seems to me that every year that appropriations to GMH are just becoming more and more regular of a line item. What would happen if the legislature just stopped subsidizing GMH? We just said tomorrow we're not giving GMH a single dollar anymore. What would happen then?
Do you want an honest answer there, Senator?
Yeah.
We're going to have to shut down. We're not going to be able to then take patients in. We're going to shut down. Is that what you want?
No, I just want to know what would actually happen if we did just stop.
That's the reality.
And
Senator, if I may answer your question in regards to why cost goes up and reimbursement go down. The cost of Medicare reimbursements have been decreasing. For example, in my specialty of surgery, it used to cost $1,500 as a professional fee for the creation of AV fistulas, and now it's down to $800. So that a lot of the costs, Medicare costs, the federal government is also decreasing costs, which decreases our reimbursements. Thank you.
And then I just wanted to touch on the rise in retirement contributions. You said you weren't sure what you were going to do to absorb that cost. looking at it, retirement contributions account for $2.5 million increase in GMH's personnel costs. But these personnel costs, they don't just affect GMH. Every GovGuam agency as a whole is affected by the same increase. Throughout the entire government of Guam, the increase in retirement contributions accounts for about $35 million increase in personnel cost. This increase in cost is not driven by an increase in retirement benefits, but rather a decrease in the revenue generated by investments of their retirement fund. The increase in cost is to pay down current unfunded liability of the Government of Guam Retirement Fund, which as of the beginning of FY2024 stood at $1.21 billion. So in short, we are paying for the sins of the past, for the past legislatures and leadership raiding the retirement fund while promising retirement benefits it could not sustain with those raided funds. We are paying for the consequences in very real dollar terms every fiscal year. If we do not fully fund the Guam Memorial Hospital, we've seen in the past that some of the things that fall by the wayside when GMH is short funds is vendor payments, utility payments, and retirement fund contributions. These things threaten the ability of GMH employees to retire. What shortfalls, what are these going to do to your operations, these increased retirement benefits year over year?
We include the estimate of in FY 2026, it'll be 34.8%. So that's all factored into our calculation of what we expect our expenses to be in FY 26. And it becomes part of what we calculate as what we will need in FY 2026. So part of that is what we're requesting as additional appropriations in the 21.9 is because we are going to have to pay more for retirement fund contributions. But for the record, we are current with our current payables to retirement. We do pay them on time, so the employees can retire.
Thank you for that. I really think that despite the budget request being significantly higher in years past, I think as a body we should consider fully funding GMH to their request. You know, even though this is higher than what it was last year we still had to do supplemental appropriations in the middle of the year. So if that's the case, let's avoid that path of supplemental appropriations down the line and just get it done now, instead of having to come back here in 6 months in the spring trying to figure it out with excess revenues, if we even have excess revenues. You know, there's a lot of uncertainty, especially when it comes to the federal government under this new regime, and that's something we definitely have to plan for. And if we're going to plan for the long term, let's prorate it out the year now. Let's do it now. Let's not try to rely on supplemental funding, some excess resources, excess revenues to pay it down the line. So with that, I urge my colleagues to support fully funding GMH to the tune of what they request, because you know, we're either going to do it now or we're going to do it later. They're literally asking for the funds to just keep the hospital together. That seems to be the takeaway I have from what I've heard today. And even though it might come as quite the sticker shock to us, if that's the price, that's the price. So let's get it funded. With that, I yield the rest of my time. Thank you, Mr. Chair.
Senator Parkinson. And yeah, that's an excellent speech, and I don't disagree. The issue is the governor has issued a ceiling. The issue is there's finite resources. So I welcome your participation in defunding other agencies, moving money, and finding that revenue within the ceiling to be able to accomplish that mission. And I look forward to your submission on that. I would like to do a follow-up, a very short 3-minute or two-question opportunity for each senator. I've been asked, and so I'm going to keep it succinct to the budget. Senator Montanani, do you have any?
I don't have any questions, but I think I've made it known that when it comes to the priorities, at least for me, it is education, public safety, and healthcare, and other agencies, other areas should be aware that the things that I plan on proposing and doing, it's cut, cut, cut. Because we have to make sure that those three priorities or agencies are the priority.
Looking forward to it.
Thank you.
Vice Speaker?
Thank you, Mr. Chair. Just to follow up on Speaker Blas's, the Community Development Block Grant Disaster Relief, right? And I believe what it was is it was like 108 million for infrastructure, 200 million for housing, 40 million for multi-family rental, 30 million for economic revitalization, and then the GURA's admin and planning of 25 million. But it seems that the 6 million, the unallocated, is going towards GMH for architectural and engineering for their relocation. So how much of that CBD, the disaster relief funding that you guys, I know you said you only gave a list and nothing solid as to funding amounts, but I think perhaps what you should have done is put dollar figures to it, because already now the comment period is coming. It started May 1st, so hopefully you guys will be able to still submit some type of amendment or something to your letter and ask for a dollar amount versus just, because if you tell me you need a generator, I'm going to give you a 2.5K generator and not a 350 kilowatt generator, right? I mean, those are the things that you really need to stress and put item by item, and put a dollar amount by it so that you can ensure that when it does come out, this is what you guys asked for, and hopefully you'll be able to get it versus this is what we received from you. We only received a list, but no dollar amount fixed to it. So we're only going to give you what we feel is going to be, that would suffice for those projects. And the only other issue or question I have is this: what I have on the drive is the proposed 2026 staffing pattern. Is this updated and the most complete, accurate staffing pattern? Because I see individuals here, and you're nodding yes, but I see individuals here that are no longer at GMH but are still slotted in the position.
When we create the staffing pattern for the budget, we're actually using either the December or January payrolls to create it. So yes, between then and now, we have had new hires, people resign, retire, so there will be some movement.
I see, okay. And then the only other question is, who is the consultant that you guys, what's the name of the consultant that you guys have been talking with at, whether it be GURA or like at Guam, Gita or DOA, wherever it's at? What's the name of the consultant?
His name is Andy Lika.
Okay, and what company does he represent? Do you know, or is he just the individual consultant?
I think he's just his own consultant, but he's the former CEO at the Good Samaritan Hospital in California, in LA.
Okay. All right, so just a little bit update on that disaster relief grant. So kind of like really put numbers behind it versus just what projects you guys are listing. All right. Thank you, Mr. Chair.
Thank you, Vice Speaker. And if the committee can also get a copy of both of the letters that you sent, we'll leave that for the committee report. Speaker Tlal, you have 3 minutes.
Mr. Chair. So how many non-medical above-step hires did GMH hire since April 2024?
For that, Senator, just a minute. I have that paper. Can you be specific about when in April? Is it April 1st?
Sure, April 1st.
So it looks like we have non-medical, I can give you the totals, 61 in 2024 and 32 in 2025. For non-medical, 5 in 2024, and 4 individuals in 2025. So just 10% of all above steps were for non-medical positions, and they were accountants and IT positions.
Accountants and what?
IT.
Oh, okay.
Yeah.
And HR and public information officers, right? What about the medical profession, medical then, the rest, the bulk? What is that? Doctors? What?
Nurses.
Nurses, okay.
Yeah, a large majority for nurses, and about 5% were for pro support positions like our technologists.
I'm sorry, like what?
Pro support positions like our technologists would make up 5% of the difference.
So the techs are, okay.
Respiratory therapists and radiology technologists, those
Okay,
are the
good.
professional support.
So I heard you mention that when the last time we did the rebasing, GMH was successful. They had a consultant at that time. What did they pay that consultant, or what would you expect to pay a consultant if you're going to hire one?
I don't remember the cost of the prior consultant, but I would think one would cost between $100,000 and $200,000 probably now. I may be incorrect, but I think the prior consultant was around less than $100,000, I think, for that year.
But do you think the results, if we are successful, first of all, has anyone other person or entity been successful in this type of rebasing that you're looking at? Like you said, it went from $1,000 to $10,000 differences.
Not to my knowledge.
All right, so we would be the first if we are successful. But we should be able to count on at least some reimbursement, even if they don't agree with the $10,000, they would give us some, because some of those rates should be reimbursed at a different rate.
Absolutely. Mm-hmm.
So it's worth it, the $100,000 to $200,000 investment. Yeah. And all right. So yeah, I guess that and the critical access hospital designation, is it just going to be relying on the congressman, or are you going to do anything else? Is there any other work that you need to do?
Because of how the federal law is set up, it will actually take an act of Congress to change the critical access hospital designation because of the bed requirement. And then there is another requirement about mileage and average length of patient stays. And so they're looking at actually just create a number of options, whether it's amending those requirements or even creating a separate category for like island hospitals, us Virgin Islands. But there are a number of different proposals on the table, but it would take an act of Congress to find a way to bring us and like the Virgin Islands into that designation.
I'm also working with Dr. Eileen Natuzzi, who is a retired surgeon who works on Solomon Islands, but she also works with the American Samoa Congresswoman, Amata Magaʹhågan. Mm-hmm. So there's been discussions at that level from that angle to help us, and not just GMH, but not just Guam, but for the other islands, to also get the critical access designation that is unique to the islanders.
Okay. And then, so those again, they're like old ideas. I'm glad you're revisiting them. I'm glad we have some progress. I hope that's progress on these. But what of your ideas for potential cost containment strategies was this outsourcing outpatient clinic spaces? That sounds to me like a rehash again of, I could, if I remember correctly, that was the big contention we were having back in like 2017, is that there was a proposal back then that they wanted money to invest in the hospital so they could refurbish it for outpatient revenue, right? For doctors to use and to generate revenue. But you say outpatient clinic space for cardiology, gastroenterology, and pulmonary services. Are these, what space are you talking about? Is this like your updated spaces, or you're talking about the outpatient clinic that you have outside?
The second floor is what we use for those outpatient clinics, but it started out really with cardiology. Mm-hmm. And these are services that really the island needs, and so that's why we take it upon ourselves to make sure to make it available. But in terms of contracting it, where then these providers can then be the ones to own the outpatient services, and but they will rent the space at the hospital, and then they have the freedom as private entities to procure the supplies, the consumables for the procedures that they need for the diagnostic procedures or diagnostic treatments. So, you know, really that's an option that we're talking about. We haven't had much of any definitive, but we're still discussing it as far as how we can make that, you know, if it is a viable option.
So, for example, cardiology, how your equipment or their equipment? Your equipment?
It's our
Your
equipment.
equipment, your space, and they would, their patients, all their patients, or your patients also?
Well, see, those are the details that we haven't really,
I see.
you know,
Okay.
talked about, but those
Is
are
this
the
similar
details
to
that
that
we need
proposal back then? I think when Mr. Byrne was at the hospital as the CFO, they had talked about that was how they were going to save the hospital by increasing revenue. Maybe Dr. Eusebio remember this. I think the OR was part of that they said they refurbished the OR. Now we're going to get additional operating doctors, surgeons to come in.
Thank you, Senator Lai. This is a line I think is going to be in line with a follow-up roundtable. It really is going that direction. So for the budget purposes, I want to thank you for your questioning. Speaker Blas, do you have any additional questions?
Oh, no, thank you very much, Mr. Chair. I'll save my questions for the different hearing, but thank you very much.
Jesus Masi, Mr. Speaker. So in closing, 3 observations that I have. Lillian and team, I just got to say that with the critical nature of your cash flow issue, Yuka, I think it's unacceptable right now that DOA is holding you to reimbursements at this point. I think it's very critical that you go back to work with DOA and work with the governor, because that's unsustainable. My one question to you is your allotment scheduled on time, and have you requested any advance allotments given your current critical situation?
Allotments do come in on time, and we did request an advance earlier this fiscal year in October. So they gave us $5 million from the pharmaceutical fund to pay vendors, which is what we're paying back now with the Medicaid advances.
The one thing that I don't have a problem with is I don't have a problem with the issue on the 6.19% in terms of that, that request. I think that should just be a no-brainer for them straight away. The reconciliation is going to happen anyways.
Yes.
So I've always said to you, and I said to you this in pre-budget meetings, the bottom line is that one way or the other, that dollar figure is getting reconciled. But the truth is, it is tied to that pharmaceutical fund, and it is by budget appropriation. So I also ask that you work with the governor, work with DOA, that they have to understand these critical situations that you're in right now in terms of that requirement. Just in closing, once again, I'm to the point where the reality is, like I said, and it's been mentioned a couple times here, that the issue of the hospital right now, and I'm going to write a formal letter to the governor and DOA to ask why that transfer authority is not on the table at this point. And the reason why I'm saying that is because it really is, at this point, the general fund, is getting to a level where it's really, really inching up towards your actual revenues in terms of what you get for fees and services. And to me, at this point, until anything changes, you are, in my opinion, a line agency of the government for all intents and purposes. And so if things need to change in law, then they need to change in law, because I'm going to continue to say this. An appropriation is not cash. An appropriation is to raise levels. An appropriation under a supplemental appropriation is typically not counted towards fixed costs. But they've become fixed costs, and so we're here where we're at now. I can tell you we're going to work with everything we got to get you to your requested level. We're going to have to really work together in terms of finding the funding for the CIPs. But I'm going to welcome all of my colleagues, to work with me, to cut, to find other agencies, to do what needs done in a bigger conversation going forward. So that's what has to happen. There is no way to raise revenues in the current projection right now. And there is no way that I will do under my leadership putting us back into deficit spending. It's not good for Guam. It's not good for our situation with regard to our current bonds, our credit rating, everything else, it is the wrong way to go. So the bottom line is that we have to live within our means, and we got to find that money. That's what it comes down to. We have to hold everybody accountable for what requests are in, and that'll be subsequent hearings that we have coming forward, and that will be lots of fun in August on the floor. So with that, a little bit of housekeeping to close out this budget hearing. This will conclude this afternoon's budget hearing on Bill 4438 COR relative to the Guam Memorial Hospital Authority. The committee will continue to accept written testimony on the bill within 7 calendar days from today, which can be addressed to myself, Senator Christopher M. Dueñas, as chairman of the committee, and mailed to 163 West Chalanzotapapa, Magaña. You may also send your testimonies to my email at senator.dueñas@guamlegislature.gov. This afternoon's budget hearing is now adjourned, and the time is 5:21. Si Juz Masi, and we stand in recess.